and let's start to the afternoon session. How many of you are doing the stress echo currently in your institutions, either DSC or exercise stress echo? Let's see a show of hands. Yeah. Where are you that you're not doing stress echo? Where are you in the glasses and the green shirt? Yeah. Where are you working, studying? Where are you studying? At Jayadeva. Jayadeva, you should have stress echo, no? DSC?
Practical. There is no exposure for practical there.
No exposure. Okay, okay. All right.
We know
How about-
theoretical. That's all.
You know theory, but you don't have hands-on
Never saw.
practice. Okay. How about on this side, this back corner? Where are you studying that you don't have access to stress echo? Gentleman in the white shirt. The backbencher. Yeah, yeah, yes. Where do you study?
RR RR institution.
In Aura, that is a very big institute. In South Bangalore, no? That one. You don't have a stress echo? And how many of you have access to 3D echo in your hospitals? Raise your hands. Jaydeva, you would be having, no? Yeah, raise your hand. How many of you have access to 3D echo? Raise your hands. So apart from the students at Jayadeva, nobody else, is that right? Any students from Narayana here? No? Any students from Manipal? RR students, you don't have a 3D echo?
So we don't have our own hospital, sir.
Don't have your own hospitals. Where are you working then?
So we will go for postings for other hospitals.
Okay, okay, TK. So let me just give you some guidance on what to do when you graduate from your program. Everyone listen. Yeah, everyone listen to what I'm going to say. So you see, your first job after you graduate is your most important one because it will set the pace for your subsequent jobs that you will come into. You won't stay in the same job most likely for more than 10, 15 years. Most people in your age group. So you probably go from one place to another every 2 years like this. What this means is that that very first job is important. And what I suggest that very first job, you go to a big institute where you get a broad exposure, okay? Don't go to these Mickey Mouse small hospitals, okay? And definitely do not go to private clinics. Even these big multi-specialty outpatient clinics, don't go there. Why? Because their business model is different. What they do, they'll put you in a small room for doing echoes. The echo room will be the size of a closet. Correct? No, you would have seen this, yeah? It's the size of a closet. Correct? You've seen this before. Have you seen like this? Yeah? Echo room is the size of a closet. And what do you expect it to do? In 1 hour, you have to do 10 echo studies. Correct? No? Yeah? And if you get a difficult patient, let's say you get RCM, restrictive cardiomyopathy, then what happens? You're like, haba, such inconvenience. Now I have to spend 20 minutes on this case. Patients will be complaining. The backlog will be there. Those types of settings, outpatient clinics, they don't prioritize difficult cases. They want simple cases. Someone comes with executive health screening. What are you going to learn from those cases? Tell me. Nothing. It will be negative learning from you. Whatever you have gained in your CCT course, going to such places, it will be negative learning. So priority number one, go to a big hospital. Priority number two, work for someone who is a senior physician, who knows the work and who will guide you. This is important. They have to be able to guide you. Having a senior physician who is not accessible is no help. Having a senior physician who will guide you, they are worth their weight in gold. Correct? No? We had this with Dash, sir. Yes, we're so lucky. So you need that senior physician to be able to guide you. You need an MSc CCT to guide you. So that you, or even we have here, we have Chandrapa, we have our own tech who has some 20 plus years experience. He's superb, right? So who is your seniors who are going to guide you? Look before you join that institute. The third bit of advice, okay, understood, no? Makes sense what I'm saying. It's not shocking, no? Number one, go to big institute. Don't go to Choto Moto type of clinics, waste of time, negative learning. Number two, go to a place where there's a senior available to guide you. That means both physician and CCT side.
Sir, I'm just interjecting. This is something you will not learn outside of this institute. Please listen to this. Stress echocardiography, sir, can teach you so much. But this is something which I have also learned from sir. So please call your colleagues if they can, if anyone's not come. Sorry, sir.
And then the last thing is, you need to see more cases. You people have not seen enough cases. I can tell just by watching your expression. Your level of training is not to the mark. Your level of training is not to the mark, CCT students. You are not where you should be. How many of you are third year students? Raise your hands. But in my opinion, you are not worth third year students. Your level of knowledge, your exposure, your clinical fund of knowledge is not to the mark. It's not where it should be. You need to see more cases. You need to see more cases. That is how it goes. And so you need to see difficult cases. The first time you saw, like Dr. Satish sir had put a ventricular septal rupture, the first time you see that should not be in the CCU, right? You should have seen 10 of those, either online or in conferences like this one, and you should have seen that. It's, ventricular septal rupture, I know this. And even if you're not the one who has done the initial echo, afterwards you go and do the echo yourself. Suppose that somebody else does the echo. You still take the echo machine and you go and do the echo on that patient. Understood? This is how you will learn. And then you read about ventricular septal rupture and all of its different manifestations, anterior versus inferior, mortality rate, Swiss cheese type of VSR, etc. Okay? Right now, your level of knowledge is not to the mark. Okay, let's start. Stress echo. All of you need to know this. This is going to show up on your exams. Guarantee it. Okay? This is going to show up on your exams, either on your final exam or on your practicals. So make sure you know this. This particular talk is based on the 2020 ASC guidelines for performance of stress echo. And by stress echo, I mean both exercise and dobutamine stress echo. And what I'm going to talk about is the indications and the contraindications, what type of stressor to use, when to use exercise, when to use dobutamine, and then some tips and tricks. This will help you a lot. And then how to interpret, and then we'll finally go over some special cases, including viability and some other applications. Okay, so when will you do a stress echo? Because the biggest one will be rule out CAD for ischemia, correct, right? Maybe the patient has angina, exertional dyspnea, or some equivalent. Maybe the symptoms are new symptoms, or maybe they are worsening symptoms. Patient has had stable angina for a long time, but now it is getting worse. Perhaps there's a patient coming for preoperative evaluation for cardiac fitness, and they have 2 or more risk factors, and they have a low functional capacity. Maybe it's not so common. These first 2 will be the very most important ones. Less common will be to evaluate clinical significance of a borderline lesion on CAG, some 50, 60, or 60+% stenosis, not 70, where FFR is not available. And so they do a stress echo, DSC, to evaluate that lesion. And then finally, patients with a prior PTCA or CABG who have cardiac symptoms. Please do not waste time. Do not do TMT on patients with prior PTCA. Do not do TMT on patients with prior CABG. It is a waste of time. TMT is not meant for those kind of patients. It is a screening test for low to intermediate risk patients. Don't waste time doing TMT on such patients. Another common reason why we do DSCs is viability. Now, the clinical standard in India in 2026, viability is done by cardiac MRI or by FDG PET. But a lot of patients don't have access to those tests. Here I'm saying in this hall, you don't even have access to DSC. What then PET and FDG and cardiac MR? So then DSC becomes a very good option for such patients. A cardiac MRI scan outside in the private hospitals cost about 11 to 20,000 rupees. A DSC you can do it for 5 to 7,000 rupees. So it may be a viable option in terms of financially affordable for some patients. And then finally, there's some indications like valvular heart disease, like low gradient, low output AS, and then some specialized things that we'll briefly touch on. Now, in the pediatric patients, we can also do stress echo, not DSE, but exercise stress echo. So we do this, for example, with Kawasaki's disease with coronary aneurysms in heart transplant patients. Why? We know that CAG is the reference standard for evaluating transplant-associated coronary artery disease. But because these are pediatric patients, we don't want to expose them to repeated radiation. So in such patients, we may do a stress echo. DTGA, patients who've had an arterial switch operation, anomalous origin of the coronary artery, and something called familial hyperlipidemia. These patients typically develop CAD in their late teens or early young adult years in their 20s. Thing about pediatric stress echo is that because these are young patients, they have a very rapid heart rate recovery, and so they tend to go back to a slower heart rate very, very fast. So you have to be a bit astute to be able to identify these or evaluate these type of patients. Now, do not do DSC. Now, this is going to be exam question for you. Pay attention. This is exam question. Do not do DSC or any type of stress echo in these conditions, including TMT for that matter. Acute coronary syndromes. Patients need to be chest pain-free for 24 hours. Troponin should be negative. Severe cardiac arrhythmias, even uncontrolled cardiac arrhythmias like atrial fibrillation with tachycardia. Severe hypertension, generally more than 180 systolic. Symptomatic severe AS. Mobile LV thrombus, like that scary picture what Dr. Satish showed with that big, huge LV thrombus. No. Don't send them for stress echo. And then, of course, decompensated heart failure. This is true for all stress testing, but it's especially required for this. This is another exam question. This will show up on your practicals, okay, in one way or the other, or you have to draw this out on your final written exam. This is exam question. I'm giving you all exam questions today. What is going to show? If you pay attention and learn this, you will score much higher. What happens during the ischemic cascade? Let's say someone has a stenosis. What will happen is they will have increased flow and they'll have coronary vasodilation. Okay, let's say someone has a stenosis. This isn't a patient with a normal function. Let's say they have some blockage somewhere. What happens then? So as the flow increases because of exercise or medications, you first get a perfusion abnormality. This is where SPECT and other things come in. Then you get diastolic dysfunction. So E to A ratio changes. Then you get abnormal strain. So you see that your global longitudinal strain changes or your segmental strain changes. Then you get wall motion abnormalities. That's where you get regional wall motion, and that's where stress echo is useful. Then you get ECG changes, and that is where TMT is useful. And then finally you get angina, and if the ischemia continues, you get infarction and scarring. Okay? So this ischemic cascade you need to know, and you need to understand that perfusion abnormality, diastolic dysfunction, and wall motion abnormalities, they all precede ECG changes and angina. Okay? All right. This is a big slide. I know I'm not going to go through all of this, but what I wanted to show you is that there are different types of stress testing modalities to do a stress test. You can do an exercise, like what we do with TMT. You can either do it on bicycle or treadmill. You can give inotropes like dobutamine, and you can do vasodilators, but honestly, I have not done a vasodilator stress echo for 25 plus years. So I'm going to put a big X on this last column, and we'll just focus on the first two. See, if you're doing exercise, it doesn't matter if it's a bicycle or treadmill exercise. What happens is, this is how you should really stress people. If they can exercise, don't do dobutamine. Make them walk on the treadmill. It's better. Yeah, bicycle stress, they say, I know, is easier to assess patients when you are want to do diastolic function, like you have a patient with heart failure or suspected heart failure with preserved ejection fraction true. But can you imagine putting a 70-year-old auntie who hasn't ridden a bicycle since she was 10 years old onto a bicycle stress test? It's just not going to happen, you know? So treadmill is what we prefer because all of our patients know how to walk. It's what they do regularly. So what happens is you exercise, you increase myocardial O2 demand, heart rate goes up, stroke volume goes up, systolic blood pressure goes up, typically by more than half. Myocardial contractility and blood flow go up. And this is how you can stress the patient. And the same contraindications that I just listed are described here. Now, if the patient is not able to exercise because of orthopedic limitations, because of prior stroke, because of debility or frailty, then you can do dobutamine. And what this does is it stimulates these beta 1 receptors, causes increased heart rate and increased contractility. And it's also the preferred way to assess myocardial viability, right? We don't assess viability on an exercise stress echo. We use a dobutamine stress echo for viability. The same thing happens, you increase myocardial oxygen demand, and the same contraindications, except you can't use dobutamine for people who have a hemodynamically significant LV outflow tract obstruction. In other words, people with HOCM, or patients with dynamic LVOT obstruction, such as post-MI, where they have SAM, systolic anterior motion from MR, like in Takotsubo's cardiomyopathy, they might get that. Or in patients with subaortic membrane, you can't use dobutamine. So other than that, the same contraindications. Now, there are things that can reduce the sensitivity of a stress echo for CAD, whether it's exercise or dobutamine, and you should understand this as well, because these are the patients you don't want to take into your stress lab. Patients with the left bundle branch block. Why? Because you have a systolic motion of the interventricular septum, and when you exercise or stress the patient or give them dobutamine, that systolic motion just gets worse or gets more pronounced, and you don't know, is that because of ischemia or is it because of the underlying conduction disturbance? This could be, say, post-cardiac surgery as well, so that you don't want to use these patients. Patients with LVH, mild LVH, sure. Moderate to severe LVH, no. Don't do stress echo unless you're doing exercise stress echo for HOCM to look at inducible gradients. Patients with previous significant MI, I mean where their EF is like 30% or so, unless you're doing a viability study. Pace rhythms, nah, you can't do that. You can't do stress echo on these patients. They need to go for some kind of nuclear study. And then patients who have an inability to reach their age-predicted maximum heart rate because of chronotropic incompetence. Okay, so let's talk about exercise stress testing and pharmacologic stress testing. Are you guys with me now? You understand? We've already covered 3 test questions, right? First test question was ischemic cascade. Second question was indications, contraindications for stress echo. These things you have to know. Okay, when do you do exercise stress testing? We said you can use bicycle, you can use treadmill. Here in India, we prefer treadmill. It's easiest to use. You also, as we said on the ischemic cascade, you know that wall motion abnormalities are going to come before ECG testing. Pharmacologic stress testing, if the patient can't exercise, you use drugs. And what are those drugs? You can use sympathomimetic agents like dobutamine, or you can use vasodilator stress, where the cardiac artery, coronary arteries vasodilate and then can induce stress that way. We're not going to talk about that in today's topic because it's hardly ever used. And then there's something called atrial pacing, which is an old historical way to stress. So really it's dobutamine. Dobutamine at low dose stimulates both the alpha and beta 1 receptors, so it has an inotropic effect, sorry for the spelling. And then at high dose, it focuses on the beta 2, so it has a chronotropic effect predominantly. Things you need to know about dobutamine. This is another test question. Okay, giving you all test questions here. These are all like, you know, you're playing cricket IPL and the bowler is just going like this, puchu, and throwing the ball to you. You should all get sixers from these, okay? Half-life is 2 to 3 minutes, so that means when you turn it off, the effect of dobutamine goes away within 5 minutes. But it can trigger tachyarrhythmias, less than 0.5%, but you don't want to use this in patients with unstable ventricular arrhythmias. Patients with a VTAC, VFib, history of VTAC, VFib, don't do dobutamine stress echo. It's got plenty of side effects. It can cause hypotension. It can cause hypertension. Hypotension, usually in little old ladies, most commonly. Patients with dynamic LVOT obstruction, like I mentioned. It can cause chest pain, nausea and vomiting, headache, tremors, palpitations. Those are all common with dobutamine. And typically how we do, we either start at 5 or 10 micrograms per kilogram per minute, depending on your hospital's protocol. And then we increase the dose from 10 to 20 to 30 to 40 every 3 minutes, just like 3-minute intervals that you do with TMT. You check your BP and you have your ECG continuously, and then every 3 minutes, you check your echo. Once you get your echo images, you go on to the next stage. If the patient, and you do this until you reach 85% of your age-predicted maximum heart rate, just like in TMT, and if the patient still doesn't reach that, then you give them these squeezy things to help to squeeze and that will increase their heart rate by about 5 beats per minute. And if that still doesn't work, then you give them atropine at the doses here. When do you stop the test? Same thing as a TMT. You can just read this. I'm not going to go through this, but it's the same indications to stop the test as you would for a TMT. Okay, now let's go over some tips and tricks on stress echo. The room setup is important. Okay, so this is a typical example from left to right. You're going to have your ECG, a cardiac monitor, blood pressure machine measuring continuously. The physician or CCT tech will be there. The patient will be walking on the treadmill if it's an exercise stress echo. Right next to the treadmill will be the patient bed where you're going to do the echo. Why? Because you want minimum gap going from the treadmill to the table for the echo study, okay? And then you have the echo machine on the other side, and the tech will be ready to receive the patient as soon as he or she lies down. On the other side, somewhere in that room, you'll have your crash cart, oxygen cylinder tubing, and a full phone, working phone, landline to call a code if needed. After you do informed consent and confirm the patient identity, make sure the patient has stopped beta blockers for at least 12 hours. If not, reschedule. Don't do stress echoes on patients on beta blockers. It's a waste of time, yours and theirs. And confirm the patient is not having active chest pain or dyspnea at rest. And then confirm good windows because it's a stress echo. And what happens is when you stress the patient, either with exercise or dobutamine, windows get worse. The patient is now tachycardic, and you don't get as good imaging at peak stress as you do at rest. So confirm good windows, otherwise don't do the scan, don't do the study. Make sure all your syringes, like your atropine and metoprolol, are loaded and ready to go, your normal saline. Your defibrillator is charged and working. You have consultants in the OPD in case something is going wrong. And if you're doing an exercise stress echo, this is really important, have the patient practice going from the treadmill to the bed rapidly, okay? This thing here. And by rapidly, I mean they should be able to do it in 5 seconds. Otherwise, what happens is they'll go like this, and then they'll ask questions, and they'll tell some story. They'll finally sit down, and then they'll say, oh, my back, and something. By that time, 30, 40 seconds are gone, and you've lost your chance. Why? Because the heart rate will reduce rapidly after you stop peak exercise. And so you need to have this practice session of transferring rapidly. Now, these studies take time. An exercise stress echo in our lab takes 30 minutes, door to door, patient in to out. And a dobutamine stress echo takes 1 hour. So we do about 2 to 3 dobutamine stress echoes per day here. And so you need to be ready, and you need to have a system so that everything flows smoothly. If you have a 3D probe, do that, use it, because you'll be able to capture the images much faster. And you're going to start from a Plaques view. Now, the difference in a stress echo Plaques view and a regular Plaques view is in stress echo, am I looking at the left atrium or the left ventricle? Left ventricle. So do I need to see the left atrium? No, right? I want to see the left ventricle. So what I do is I just go a little bit lower so that I see more LV and less LA, okay? For the PSAX view, depends on your protocol. Here we do basal and mid parasternal short axis views of the left ventricle. That works well. Otherwise, if you're just doing one, then do the mid short axis and make sure you show the papillary muscles well. Make sure the LV is rounded, like Dr. Satish sir had said. For the apical four-chamber view, adjust the depth because you don't need to see the left atrium on stress echo, okay? And record with a breath held in end expiration. Make sure you make the patient practice beforehand. If you're not able to see, if you're at a center where contrast agents are used, then you can use these agents. The only thing, though, pay attention, is that when you're doing stress echo, you use low-dose contrast agents. You don't use full dose like you would do with a regular transthoracic echo. Why? Because the image will be too bright. Here you're trying to sustain the opacification for a long time. So you give a smaller dose, and then you give a slow saline flush. And then you can keep on giving smaller boluses, followed by that slow saline flush. So you're looking not for a pacification or perfusion of the myocardium, you're looking for wall motion, okay? All right, so like I said, exclude most of the left atrium. This is probably a little bit cut off. You can see the mitral annulus is coming here, and the left ventricular apex is also rounded. LV apex should be, this is probably foreshortened a little bit, but do optimize the depth. I don't need to see the pulmonary veins in this. Another thing, Use a quad screen. So if it's an exercise stress, have rest on this side, post-exercise or peak stress on this side. Same thing for mid-short axis. Now, if it's a dobutamine, then you might have rest, low dose dobutamine, high dose dobutamine, and peak or recovery, depending on your protocol. Now, there's some mistakes in this image. Two mistakes that I saw right away. The first one is, why do I need to see the left atrium on a stress echo? Right away, I know the tech doesn't know what they're doing. The second thing is, why is this LV here and this LV is here? Does that make sense? Why am I seeing the apical short axis and trying to compare that to this basal short axis? Or maybe it's mid-short axis. I can't tell if that's a papillary muscle. You see what? This has to be at the same level. Your short axis images has to be at the same level. These are real examples. Okay, some other tips for temporal resolution. Focus on temporal resolution and myocardial border, right? So I need to see the myocardial border. This is a case of endocarditis affecting the tricuspid valve. Here the frame rate is 50, which is pretty good. But look at what they're doing. Again, I know the tech doesn't know what they're doing in this case. Why? Why do I need such a wide sector if I'm concerned about tricuspid valve endocarditis? Does that make sense? No. If I'm concerned about tricuspid valve endocarditis, give me a narrow sector and adjust the depth so I'm focusing just on the tricuspid valve. Then I'll get better temporal resolution, which is shown by your frame rate, 50 hertz or 50 frames per second. And then I can see fast-moving objects much better, like endocarditis, or that motion of the myocardium, especially something called tardokinesis, which is when the heart starts to contract, but it has a delayed onset of contraction. So narrow your sector width, use a single focus only. If you have a machine that has multiple focus, use a single focus only, and make sure you turn on harmonics so that you get better definition of your endocardium. Okay, so let's go into interpreting the stress echo. What makes a positive or abnormal study? Dr. Satish showed you a very similar slide in the last talk, so I won't go over this, but this is a test question, okay? Another test question. You need to know the 17-segment model. You need to know which coronary arteries provide which myocardial segments. There's just no, and you have to be able to draw this out, just like that. So make sure you know this. This is a test question for all of you. Now, what's normal is that the entire heart should have better contractility. The wall motion should be hyperdynamic. You expect the thickness to increase by more than 40%. You should have an increase in heart rate, and the LV cavity size should reduce. So if you look at how big the cavity gets during diastole, it should get slightly smaller. If I see the LV cavities dilating during stress, that means either left main or triple vessel disease, okay? All right, so let's take a look at this case and see what we have. Sorry, that's not playing. So let's go on to this one then. What's abnormal? So typically what we look for is a qualitative approach. There are some quantitative approaches, but we're not going to focus on this for this talk. So basically, when you have ischemia, you have new or worsening wall motion abnormalities in a particular segment. Now, don't get fooled by myocardial tethering, but you're having a new wall motion abnormality. In other words, the thickening is not as much as it was before. Look for LV cavity dilation, which means multivessel CAD. And if you have a suspicion for ischemic MR, especially if you see that posterior leaflet is tethered, then look for mitral regurgitation. Ischemic MR that shows up only during stress. So normal, what should happen is that resting function be normal, low dose dobutamine is normal, and at peak stress, it's hyperkinetic. If you have ischemia, function may be normal, or maybe there's a wall motion abnormality. At low dose, it stays either normal, or you get a new wall motion abnormality. And then at peak stress, you get a worsening of that wall motion abnormality or that lack of hyperdynamic response. In other words, it's not really squeezing as much as it should. If it's an infarcted myocardium, then you would have already wall motion at rest because it infarcted, and it doesn't change. This is what we look for in viability, okay? So in viability DSCs, DSC for viability, if it's non-viable myocardium, there'll be a wall motion abnormality at rest, so it'll be akinetic, and then it doesn't get better with low-dose dobutamine. And then if it's viable, it'll have a wall motion at rest, it'll be usually akinetic, and then it will get better with low-dose dobutamine, and then it'll get worse with peak. This is another test question, what I just said. So many test questions I'm giving you for free. Okay, viable myocardium, how do you identify viable myocardium on a DSC? You'll say, ma'am, sir, there'll be a wall motion abnormality at rest, At low dose dobutamine, there'll be an improvement in systolic thickening, and then at peak or post-stress function, it will get worse. In other words, you'll have a biphasic response. You want me to say that again? This is a test question. Make sure you understand this. In viable myocardium, you will have a wall motion abnormality at rest. When you give low dose dobutamine, you'll have an improvement in systolic thickening. Thickening means the actual thickness, okay? And then at peak stress, you will have a worsening of that wall motion abnormality, and that is the classic biphasic response. It starts here, the wall thickness gets better, and then it gets worse. Okay? That's the biphasic response. And this is what you're looking for. If it's non-viable, you'll have that same wall motion abnormality at rest. It doesn't get better with low dose or high dose dobutamine. Okay, there is something called the wall motion score index. I think Dr. Satish briefly mentioned this, but you can score each segment of the 70 segment models as hypo, normal, which you give 1 point, hypokinetic for 2 points, akinetic for 3 points, and dyskinetic or aneurysmal for 4 points. You add that up and then divide by the number of segments you saw. And if you have a wall motion score index of 1, which means that everything is normal, that's a completely normal heart. If the wall motion score index is more than 2.5, that means that this patient has many segments in this range and they have a poor prognosis. So this is an example here. Let's take a look and go through this together. Okay, third person in the third row wearing the blue. Turn on the lights so we can see. Get the mic. There's no free passes in my lectures, okay? All of you have to be prepared. Yeah, so I'm looking at this turquoise kurta. Yeah, stand up, please. All right, read this study with me at the baseline. Tell me this. What segment is this?
Anterior septum,
Which one? Basal, mid?
basal,
Basal, this one?
mid,
And these segments?
basal inferolateral,
Uh-huh.
mid inferolateral.
All right. Tell me the wall motion in this. Is it normal, hypokinetic, akinetic, or dyskinetic in the basal inferolateral?
Basal looks hypo, sir.
Okay, and mid?
Uh,
It's probably hypo.
Hypo,
Yeah,
yeah.
okay. What do you say for the
where we come
basal
to
anterior septum?
anterior and basal and mid anterior septum looks akinetic.
Akinetic.
Yeah.
Akinetic. Very good. Let's give her a big hand. That was very well done. Okay. Now you can pass it on to somebody you don't know. Pass the mic to someone. Look behind you. See that guy who's looking away behind you on the left side, pretending not to see? On your left side. No, the Jayadeva guy already spoke very bravely. This one here, next to the lady in the red shirt. Yes. All right, please stand up. Let's review this. This is the low dose dobutamine. Tell me what you see in this basal inferolateral wall. Is it improved or is it the same compared to base? This is baseline. Is it improved or is it the same or is it worse? I only have 3 options. Either it stays the same, it gets better, it gets worse. What do you think? You're looking at wall thickening during systole. Is the thickness improved or not? What do you think? It might be the same also, no? Yeah, same, okay. What about this one? Anteroseptal walls? Hold the mic close. I can't hear you. No, no, this is tethering. This is tethering. See this here? This is the RVOT. This is tethering. There's no change. You're looking at thickening. You're not looking at movement. You're looking at thickening. This was meant to fool you. Okay, this is tethering. Okay, there's no change in thickness. Okay, give the mic to someone else that you don't know. Oh, you wanted to give to her. Is she your friend or not your friend? Okay, go ahead, ma'am. This one here. This is peak stress. Let's start with this one. Is it better or worse or the same compared to baseline?
Better, sir.
It's increased contractility, mid inferolateral,
Increased.
okay. Basal anterior septal,
Increased.
same. You're looking at thickening. You're not looking at rocking. You're looking at the thickness. See, look at how this thickness has increased, right? There's no change in the thickness. There's movement, but that's just because of tethering of this part of the myocardium by the normal segments that are adjacent to it. Okay, so don't confuse tethering here. What about this mid-anterior septum? Now you can redeem yourself. Is it the same, better, or worse?
Same.
Same. So would this basal to mid-anterior septum be viable or non-viable? There's a wall motion abnormality at rest. It doesn't get better with low dose. It doesn't get better with high dose. What is that? Viable or non-viable?
Non-viable.
It's non-viable. So this basal to mid-anterior septal is non-viable, and basal to mid-inferior lateral, no ischemia. Okay, got it? Is there any LV cavity dilation? No, it's the same.
No, sir.
Same. Okay, good. Very good. Give her a big hand. All right. So this is what I want you to know. You need to look at, see, this is when I was telling you, what was that third point? You need to see as many studies as possible. Got it? And you need to have somebody walk you through those studies so that you understand what is being shown. So this is how important it is. Now, let's just go through a few in the last few minutes. Be careful if you don't have adequate stress. If you don't have adequate stress, just say so. It becomes a non-diagnostic study. Be careful of anti-anginal therapy, because especially beta blockers. They may not reach target heart rate. Mild coronary disease, you're not going to see anything. Left circumflex disease is notorious for causing false negative results in any kind of stress test. Doesn't matter whether it's adenosine stress perfusion, rubidium PET. It doesn't matter what you're using. It just has a low sensitivity. Poor image quality. Please do not image patients with poor image quality for stress echo, whether it's exercise or dobutamine. It doesn't matter. And delayed image. Remember, for exercise, you need to get them onto the bed ASAP. So you need to do a practice session before you start the test. False positive could be because of interpreter bias, overinterpretation. That basal inferior wall can often cause abnormalities. Remember I said about left bundle branch block and post-cardiac surgery affecting the septum. Don't send these patients for DSC. Cardiomyopathies, if the EF is 30% or less, these are not good patients for stress echo. In patients who have very high blood pressure where they get a hypertensive response, they often have a false positive result. So be careful again. Okay, diagnostic accuracy, you should just know that the diagnostic accuracy of stress echo and DSC is comparable for the most part to other modalities. That's all that you need to know. You don't need to know the numbers. And in the last few minutes, just some special indications. We talked about viability. Make sure you know viability, make sure you know ischemia, what I had showed you in that table. Sometimes you'll be asked to do a diastolic stress test. That's in people with suspected heart failure with preserved ejection fraction. And in these patients, what you're doing is your regular dobutamine stress test. And then after you do your peak stress and you acquire images, you repeat diastology. So you do your E by E prime ratio, you get your E to A ratio across the mitral valve, you get your tricuspid valve velocity for PA systolic pressure. You do all those things, the usual diastolic things, and then you do it after your stress, okay? And then the last thing is valvular heart disease, low dose, low output aortic stenosis. That's an entirely different topic. And then once in a while, exercise stress echo for HOCM, although we've moved away from that entirely, okay? So what were those three things, those three bits of advice I gave you at the beginning? Number one, go to a big institute after you graduate. Yeah. Number two, work with a senior faculty who is accessible. Okay. That could be a CCT, could be a cardiologist. And number three, see more cases. Just like what we did today, see more cases. That's exactly what you need to do. Okay, let's go into strain. Let's go into strain. So strain is a bit different. You still cover a lot of CAD, but it can be used for many other conditions as well. And I'm going to unpack this for you in a way that will be easy for you to understand. So what is strain? Strain is like the deformation of the myocardium between 2 points. In other words, if the myocardium is this much to start with, and then it becomes this much, then what is that difference? That is called strain. And we can explain this by use of a spring. Now, not this kind of spring, this kind of spring, the spring that you would have on your clicky ballpoint pen. So imagine that the spring is 1 centimeter long, okay? okay? And then during systole, or let's say during diastole, let's say it becomes longer, and now it is 1.2 centimeters. So what's the difference in percentage? 20%, right? That's strain. That's all that you're using with strain is 20%. So if it's 1 centimeter, now it came to 1.2 centimeters, the 20% difference, that is strain. So it's the change in deformation from one form to the other. And how we do this in modern format is we use something called speckle tracking echo. This is a patient with HOCM, with asymmetric hypertrophy of the interventricular septum. And in this segment here, what it's showing is that the machine will track, see all these little speckles here? Some areas are bright or hyperechoic, and some areas are less bright or hypoechoic. It will track all these speckles, and it will watch the movement in this direction, in this direction, in this direction, and then it will look for that deformation. How much is it changing in length from systole to diastole? And that's how we measure strain. And typically we do this using the same, in this case, 16-segment model that we use for coronary artery disease. So that's why the 16-segment model, you have to know it. There's no way around it. You have to know this. We can then look at segmental strain, where we look at just say the strain in the LAD segments, or maybe the RCA territory. We can look at something called global longitudinal strain, where we look at strain across all the different views, and we can see what that strain is. And this gives us a lot of information about the health of the myocardium and what's likely to happen. There's something else called strain rate. So a strain is the amount of movement. Strain rate is how fast it moves. Strain rate is not as useful as strain. So in today's talk, we're just going to talk about strain, and we'll just focus on this. There are all types of other strains. Don't worry about those. All you have to worry about is longitudinal strain. So how do you do this? You take your apical 4-chamber, apical 2-chamber, and apical 3-chamber views. And then you will have the computer measure the endocardium and the epicardium of the left ventricle in all of those views, and then come up with these strain measurements. It will do it automatically for you. Okay, so this is how it does. Now notice what happened when I went from here to here. In this segment, are we able to see the mid-anterolateral and apical anterolateral wall? Lateral? No, okay. So what you want to do is you need to adjust your view so that you're focusing just on the segment of interest. In this case, you can see now that there are no segments of the LV that are outside the sector. Got it? Okay. I've also cut off my left atrium. Unless I'm doing LA strain, why do I need to see the left atrium? So this is how I would do LV strain. So first from the apical 4-chamber view, and then I would combine it with all the other views to get my total strain. And you can see in this case, I've got a global longitudinal strain of minus 18.8%, which is quite normal. The average value somewhere around minus 18%, with higher numbers, that is 18, 19, minus 20, it's a negative value being better, and values that are less large, not really, but because it's negative, minus 15, minus 14, minus 10, these are associated with the worst prognosis. And the red lines, you can see that the strain is abnormal, and as a strain is normal, sorry, and as strain gets abnormal, it becomes yellow and other colors altogether. So what we do with strain is we're able to tell a lot more information than we get just by looking at ejection fraction and wall motion abnormality alone. So it's like taking an apple, which on the outside looks okay, but when you cut it open, you can see that that apple is no good. This is what strain allows us to do. It's a very powerful tool, often underutilized tool, but a very powerful tool. Let's first talk about CAD, and then we'll just briefly touch on some of the other applications of strain. We can use this for chest pain in the ED. Someone comes to the emergency department with chest pain, you can do your quick echo and then do strain measurements there. You can help to diagnose acute infarction where they have a non-ST segment elevation ACS, or they have an ACS but no negative troponins. You can do it for prognosis after MI. And we can also do stress echo. We've done a lot of stress echoes where we do strain analysis as part of the stress echo protocol. But you can use it for heart failure with preserved ejection fraction or heart failure with reduced ejection fraction, for assessing diastolic dysfunction, for prognosis, for certain types of non-ischemic cardiomyopathies. This one is a test question, by the way. We're going to go through that in a minute. For transplant cardiomyopathy, which is where you get coronary artery diseases after heart transplant, leading to weakened heart, and in patients with LVAD, we want to see, are they improving after being put onto some kind of mechanical circulatory support. Okay, let's focus on this. This is from a study published a while back. They looked at 143 patients referred for CAG. Everybody had normal EF, no wall motion abnormalities. They all underwent echo and CAG. They looked at their strain, global longitudinal strain. You forget about post-longitudinal systolic strain for now, just global longitudinal strain. And what they found was, and they wanted to see how good is global longitudinal strain for predicting a stenosis of 75% or more. And what they found is that in non-diabetics, if the strain was worse than minus 18%, or in diabetics, if it was strain, see, diabetic strain is usually 2 points lower than non-diabetic. If the strain was worse than minus 16%, just by global longitudinal strain, it was better than a treadmill test for diagnosing CAD. That's how powerful global longitudinal strain is. These are some examples that they gave. Look here at this first example. This is a normal patient. Everything is red. You can see the apical four-chamber view here. Global longitudinal strain or global strain is minus 23%, right? We said normal is around minus 18. And when you do the angiogram, is it normal or abnormal? Normal, right? Okay, let's look at this patient. This patient has minus 15.7%. It's an abnormal strain, but slightly abnormal. It's not terrible. And this CAG looks relatively okay, all right? Now let's look at this patient, almost the same strain, minus 15.6, but in this case, you can see there's severe disease in the mid-LAD, right? And then if you look at this patient here, where the strain is minus 14.1%, you can see that there's, in this case, two-vessel disease. So strain can help you to identify patients with CAD when ejection fraction and wall motion is normal. And what they found is that the worse the strain, as the strain went from normal, around minus 18, minus 19, to worse, that the more likely they were to go from single vessel to double vessel to triple vessel disease just by doing strain. And this takes like 3 minutes to do, okay? It's very easy to do this. Now, let's just go over some tips and tricks, because you need to understand how to get good quality images. First of all, don't cover the pericardium in your strain ROI. Be careful with the annulus and apex. You don't want to cover that also. So for example, here, if you look at this image, right? I can't really see the rest of the heart in this one. Maybe this is better here, yeah. So you don't want to go out into this part of the heart. You don't want to go out here. You don't want to go anything off of this, right? So this is one important part of how you would assess, how you would acquire these images. Your ROI should be not too wide or too narrow. So you're covering just the entire myocardium. And you want to exclude segments that you just can't see well. Sometimes it happens, you're not able to see the segment. In that case, don't make it up. Exclude it from your analysis and don't count trabeculation and papillary muscles in this. So these are the things that you need to do to make sure that you have good quality strain. Once you do that, then your study is likely to be accurate. This is a 44-year-old male, had an angioplasty and stent to the LAD back in 2014, comes in with recurring chest pain, but his ECG, echo, troponin are all normal. Everything normal, okay? This is apical 2-chamber, normal or abnormal? Normal. Apical 3-chamber, normal or abnormal? Normal, right? Notice he's breathing here. It was not, when I see a study like this where the patient is breathing, I will scold the techs because they did not take this during breath held in end expiration. Okay, now let's look at a strain analysis. Okay, so we put the ROI over his, in this case, the apical 4-chamber view. We excluded these trabeculations and other things. We make sure we captured all the segments. Any segments we don't see automatically get excluded. And what we see is we get a global longitudinal strain of minus 14.9%. Is that normal or abnormal? Abnormal. What do you think this is going to show? Normal or abnormal CAG? You would expect to see an abnormal CAG based on this. So what do you see here? Here's a stent, and you see the disease, right? Significant disease, in-stent restenosis at 90%. So this is how strain analysis can help you to make the diagnosis and suggest what is likely to see. Now, last few minutes, in patients with HFrEF, this patient has what looks like non-ischemic dilated cardiomyopathy. Maybe there's worse wall motion abnormality in this inferior septal wall compared to the lateral wall, but I can't see this distal lateral wall at all. Left atrium looks enlarged, RV size and function normal, RA size is normal. Okay, when we do global longitudinal strain, I think we got a number of minus, let's say it's around -8 to -30, -12 is what it looks like the average is. What happens in heart failure, whether it's HFpEF, heart failure with preserved ejection fraction, or HFrEF, heart failure with reduced ejection fraction, is that the worse your strain, the more likely you are to die. And that's what's shown here. These are people with normal strain or better strains. These are people with lower strains. And as they follow them out, they're more likely to have clinical events. So strain is bad news. The same thing happens in HOCM. Now, this is a test question. This is a test question. Tell me about the uses of strain. Okay, this is what your examiner will ask you. You can say, sir, ma'am, it can help us to diagnose CAD in patients with a normal ejection fraction, no wall motion abnormalities. A reduced strain would suggest that significant CAD is present. It can also help us to differentiate hypertrophic cardiomyopathy from LVH due to hypertension, or LVH due to amyloidosis, LVH due to athlete's heart. This is another test question that you can get, and this is how it works, okay? In an athlete's heart, what do you think the strain is going to be, normal or abnormal? Normal, right? Yeah, these are guys who are running or lifting weights. In patients with hypertension who have LVH, you think the strain will be normal or abnormal? Abnormal, right? I think in this case it's minus 15.7%, and here you can see it's minus 16.7%. Now in hypertrophic cardiomyopathy, look at this. You only see a few red areas, and all of this is very reduced strain. Here it's minus 14, minus 12, but here it's minus 2, minus 2, minus 6. These are the hypertrophied segments. And so the strain will be significantly reduced. Now, if you have apical HCM, then the strain is reduced in the hypertrophy segments, and it's very much worse here. In fact, it's actually gone positive in these segments, which it should be negative. So what you can say with strain is that it can help you to differentiate causes of LVH, whether it's HCM, athlete's heart, or hypertension. And then in this last one, it can help you to differentiate cardiac amyloidosis. This is another test question, okay? Another test question on strain. Okay, this is a study that was done at the Cleveland Clinic just shortly after I left. And what they found was that if you use global longitudinal strain in patients with suspected amyloid, you know that in amyloid, you're going to get increased myocardial thickness, right? LVH. The intraatrial septum might be thickened. Maybe the valves will be thickened. Systolic function might be reduced, but just mildly so, and you might have diastolic dysfunction. You often have restrictive filling patterns. And then the myocardial tissue velocities, your E prime or E by E prime ratio will all be abnormal, and you have to show significant diastolic dysfunction. Your global longitudinal strain is also reduced, which is no surprise. I think you're getting the theme of all of this. But here's what happens is that in amyloidosis, you get apical sparing of longitudinal strain. What that means, this is amyloidosis cases on the top, and these are other cases. I think this is HCM, this is aortic stenosis where you have abnormal strain. But if you look at the amyloid case, you have what's called a cherry on top appearance. Imagine that you're eating an ice cream cone and you're looking at it from the top, and there's a cherry on top, a red cherry. In other words, you get apical sparing of the strain. All the other segments are abnormal because amyloid protein is depositing in these basal and to some degree the mid segments of the left ventricle. But the apex is the last place where amyloid proteins will deposit. And so you get this cherry on top or apical sparing in amyloidosis. And so you can differentiate from one type of disease to the next. Okay, there is something called atrial strain. For lack of time, I'm not going to go over this, but this is mainly helpful in atrial fibrillation and in diastolic dysfunction. So what did we cover today, and what are your key take-home points? You need to know that global longitudinal strain helps in diagnosis of CAD and amyloidosis. It can help differentiate between patients who have LVH, whether it's because of HCM, hypertension, or athlete's heart. It provides prognostic value in heart failure with ejection fraction and heart failure with preserved ejection fraction. And mainly we use global longitudinal strain, but there are other types of strain like radial, circumferential, and others that we didn't talk about that are mainly used for research purposes. Okay, So we've talked about a lot of things. You've got a lot of test questions to work on. I hope you made notes. And next time I see you all, you should all be stars. Okay? I expect you all to be superstars. Thank you.
Thank you, sir. Thank you so much, sir. There's something about Solar Sir's talks I'll tell you. And this is something I have learned. I have been Sir's student from 2008. And Sir's taught all of us. He has a knack. He is extremely educated. Let me tell you, he's made this very, very simple. But that's the beauty of a teacher, to bring it down to your level and to make it simple. Because most of what is said, I think if you read around that topic, right, all of these topics, you'll probably finish a lot of strain as is used today, as well as about ischemia and viability. I request ma'am to welcome both Vijay Sai sir, who is the HOD of cardiology at Vaidehi, who will be speaking next, as well as give a memento to our own Sola sir for having discussed two topics with you right now. Yeah, Vijay Sai sir and sir. On behalf of all the students, sir, thank you so much. And I also welcome Vijay Sai sir on behalf of all the students, and I request ma'am to give him a moment of our gratitude and love. Sir also is a student of Sri Sathya Sai Institute of Higher Medical Sciences, Puttaparthi, our senior in that sense, and he's been associated with our institutes for more than almost 25, 28 years now. So sir is one of us as much. For that matter, anybody who spoke here was one of us, all of the faculty. Thank you, sir, so much for joining us today. Sir will be speaking on echo in congenital heart disease. Another very, extremely important topic and very feared topic, because there's always a fear of sight is ambiguous, this, that, in all our minds. And sir is another person I can vouch for who makes this topic really, really simple. Thank you, sir, for being on a Sunday with us.
Thank you so much, Prayag. Good afternoon. Thanks for the opportunity, Dr. Rita and then Dr. Prayag. So this is a very important subset of patients what you will be doing echo in your day-to-day practice whenever you are posted in echo room, not only now, but I think down the line also. Apart from rheumatic heart disease, coronary disease, this is an important subset where you come across various congenital heart diseases. So I'll go briefly into some of the commonest congenital heart diseases what you will be encountering day in and day out, and then we will try to discuss some of the important points. We'll try to understand how echo helps in diagnosing congenital heart disease, learn basics about pediatric echocardiography protocol and segmental approach, especially for doing an echo in congenital heart disease, identify the key echo important features of common cyanotic and acyanotic congenital heart diseases, and probably help in managing these patients with either a device or a surgical intervention. What exactly you mean by congenital heart disease? So they are all group of anatomic abnormalities of the heart that are generally present at birth. So, or any abnormality in cardiocirculatory structures or function that is present at birth. So you have various, prior to going to this, so this is the basic slide showing the segments of the basic embryology of the heart. This is the tube comprising ventricle, atrium, conotrunculus, and then again there is aortic sac, conotrunculus, right ventricle, left ventricle, then atria, then this is looping, then this is septation into 4 proper structures along with great arteries. So you all know, you would have heard about fetal circulation. So it involves presence of foramen ovale, ductus arteriosum, and so many structures. So whenever there is persistence of these fetal structures, they result in congenital heart disease. Starting from foramen ovale, it can be fossa ovalis, then ductus arteriosus, it will become ligamentum arteriosum. But if it persists, then it will lead to PDA. There are similar things to happen like this. Basic protocol in whenever you're doing pediatric echo, this is child-centric approach. You should have a warm room and probably a warm gel. You should have a calm environment, and probably sedation may be required in most of the children, especially when they are all creating tantrums. So you can use some chloral hydrate solution. It's a milligram per kg body weight, and you should have a high frequency pediatric probe. Ideal position is probably if the infants are there less than 1 month old, ideally they should be in the mother's lap, or they can be lying down on the bed. If it is slightly bigger than infant, then probably on the bed you can lie them down. Basic thing is you should have a calm environment and you should not be having any disturbance from the other resources. Tea is only used sparingly in children. Although we have, I think many of the institutes have got pediatric tea, it is not done commonly. Only in few instances where we have dilemma in diagnosing the congenital heart disease, we use tea. Basic views are parasol long axis view, then you come to the basal short axis view, then apical 4 chamber, apical 5 chamber, apical 3 chamber. Prior to this, we will be starting with subcostal view to identify the situs and the levocardia, mesocardia, and dextrocardia orientation. So you'll have to use, apart from the standard views, you also bring in suprasternal notch view, and then probably all throughout your echoes, you will be using color and spectral Doppler throughout. These are some of the images where we, normally when we start with subcostal long axis views, these are the images where we see, apart from orientation of the heart actually, whether it is levocardia, mesocardia, dextrocardia, we see the presence of IVC or aorta in relation to the thoracic spine. So this is the short axis view. I will not be going to the details of these things. This is apical view, 4 chamber, 5 chamber, then apical 3 chamber, then you have parasol long axis view, and then short axis view starting from at the great arteries, then to the papillary muscle, then to the mitral wall level, and suprasternal notch views, especially used in diagnosing coarctation of aorta or assessing the size of the PDA for device or surgical intervention. So it's basically segmental sequential analysis starting from situs, cardiac position, then the venous inflow, especially concentrating on SVC, IVC, and pulmonary veins. Then comes to identify atrial morphology based on the appendage shape and the position. Then atrioventricular connections, whether it is offset walls or common AV wall. Then ventricle morphology based on the moderator band or and trabeculations. Then trying to assess presence of septal defects and shunts. Then you come to the outflow area where you try to assess great arteries, whether they are parallel or crossed, then outflow tracts, then aortic arch, whether right-sided or left-sided, then presence of coarctation or patent excess arteriosus. These points are assessed sequentially and in segmental, this is called a segmental approach. This is a basic slide, probably you would have seen. What we are trying to see is presence of aorta and IVC in relation to the spine. And we have the orientation here. This is left-sided heart. This is levocardia, mesocardia, then dextrocardia. Venous connection, we'll be concentrating only on SVC and IVC drainage to the atria. So SVC and IVC normally drain to the right atrium. Pulmonary veins drain to the left atrium. So based on these assessments, you will be assessing the connections of venous system to the atria. Then comes to assessing the atrial morphology based on the appendage shape, LA appendage and RA appendage. RA findings are, it has got a pectinate muscles, whereas LA has got very smooth wall. RA appendage is very broad. LA appendage is narrow finger-like appendage. Then there is a thick septal limbus, whereas in LA there is got thin wall of the atrial septum. Then apart from SVC and IVC, we also see the drainage of coronary sinus, which is located in the posterior inferior part of the RA. Then there is suprahepatic IVC. Then the ventricles, this is called as a D loop and L loop. When you place your hand on the chest, assuming that heart is on the left side, levocardia, your thumb will be in the RV inlet and your fingers will be in the RVOT. This is called as D loop. The other way around, it will be L loop. And basic anatomy of the RV, I think probably you can pitch in. How do you identify the right ventricle? Based on what? Yeah, basically you try to identify the right ventricle or left ventricle starting from the AV wall morphology. Which AV valve is located towards the apex, which is towards the base. So more towards the apex is tricuspid valve, and AV valves always go with the ventricles. So whichever valve is located towards the apex, that is the tricuspid valve, towards the base is mitral valve. Then comes the presence of moderator band and trabeculations. They are in right ventricle, whereas LV is ellipsoidal, smooth walled ventricle, and ellipsoidal in shape. So these are the basic things to identify right ventricle or left ventricle. Apart from this, you have multiple small papillary muscles for tricuspid valve, whereas you have very common thing in LV is only 2 papillary muscles or maximum 3. Then I think as we discussed, tricuspid valve always go with right ventricle and mitral valve goes with left ventricle. And this is what, whenever there is an inversion, probably in LTGA, when we see there is an atrioventricular discordance and a ventricular-arterial discordance, you should be carefully identifying the AV walls and the ventricular morphology to come to a conclusion there. This is an example of AV discordance. Then types of AV connection, RA connected to RV, and then LA to LV. This is called as concordance. If there is a discordance, RA will be to LV, then LA is to RV. Then you come to the outflow tracts. Normally, RV gives us to PA, then LV gives us to aorta. And these are identified based on the presence of coronary arteries which are coming from the aorta. Then branching pattern is seen in pulmonary artery. So these are the basic things to differentiate between great arteries, whether this is aorta or this is pulmonary artery. That's what is seen here. So this is a basal short axis view, a very common view in our routine echoes. This is the aortic wall in short axis, left cusp, non-coronary, then right cusp. These are the coronary artery origins. This is tricuspid wall. This is RA, septum, LA, tricuspid, RB body, then pulmonary wall, then branching of MPA into RP NPA. So as we saw it in atrioventricular connections, here also in ventricular artery connections, this is called as concordant. Whenever the RV gives rise to pulmonary trunk and LV gives rise to aorta, this is concordant connections. If there is a discordance, meaning RV is giving rise to aorta, then LV to pulmonary trunk, it is called as discordant connections. Then in the same area, when the ventricles are connected to both the arteries, it is called as double outlet right ventricle. For example, right ventricle is connected to aorta and pulmonary trunk. Then if there is a single outlet, probably commonly seen in truncus arteriosus. Then we have a suprasennal notch view, which is useful in helping us to assess the side index of the aortic arch and the probably identifying whether any coarctation of aorta is there or PDA is there. Basically, side index of aortic arch is identified based on the branching pattern, and this is left-sided aortic arch. This is the right-sided aortic arch. So to summarize the segmental approach, we try to identify the situs based on IVC and aorta to spine. Then we try to evaluate SVC, IVC flow into which atria. Then you identify the atrial morphology, whether it is RA or LA. Then comes to the atrioventricular connections. Then ventricular identification based on the trabeculations, moderator band, and papillary muscles. And then to the outflow tract, whether it is aorta because of coronary artery or because of branching, you will be naming it as pulmonary trunk. Then come to the suprasennal notch to identify the side index of aortic arch. This is the basic segmental approach in congenital heart disease. That's what is summarized here. Great veins to venoatrial connection, then to atria, then to atrioventricular connection, then to ventricles. then ventricular artery connection, then great arteries. So some of the common probably abnormalities what we see in across the spectrum of congenital heart disease, starting from simple ASD, VSD, AV septal defect, then you have tricuspid atresia, absence anomaly, going to the complex anomalies like tetralogy fallow, DORV, DTG, LTGA. We will not be going into all the details. We will try to run through some of the commonest congenital heart disease what we encounter in day in, day out. So atrial septal defect, when you do an echo for a congenital heart disease, few things you have to remember after diagnosing the congenital heart disease. Suppose there is an ASD in that child, you have to identify the ASD location, whether it is septum, ostium primum or ostium secundum or SVC type of ASD, or it is like a, then probably the associated malformations, what it has got associations. Like commonest thing is when you have an SVSD, you will have a partial anomalous pulmonary venous return of right upper lobe pulmonary vein. So suppose VSD is that. VSD can be associated with aortic regurgitation, coarctation of aorta. If there is a PDA, it is commonly going with coarctation of aorta. So these are commonest associations. So you should be trying to assess what are the common associations and then look into those things. Then probably the effect of shunt on the heart, whether it is causing any QP by QS is more than 1.5:1 or it is less than 1.5:1, and the ventricle function. So these things, if you are able to come to a conclusion, then the treating doctor will have an idea whether this child requires a treatment or no treatment. So whenever you have a congenital heart disease, these are some of the commonest associations, like ASD with PAPVC, then VSD with coarctation PS and PDA ASD. You have tetralogy fallow. Commonest association is right aortic arch in around 25% of people. Then you have coronary anomalies, which is around 5%. Then AV septal defect. Then subtypes of TOF is TOF with absent pulmonary wall and TOF with AV septal defect. Then in TGA, one of the complex congenital heart diseases, you have common associations as VSD, PDA, and PS. So as we discussed, these points have to be brought in to know whether ASD, VSD, whenever it is there, what exactly it is causing any primary cardiac effects on the heart, like volume overload of the right heart, then pulmonary overcirculation leading to pulmonary arterial hypertension, and increased LA pressure. So these will in turn lead to congestive heart failure. So whenever there is a right-left shunt, probably because of these things, classical entity is tetralogy fallow, you will have RV hypertrophy, then probably cyanosis and then cyanotic spells. Then you have reduced exercise tolerance. You have an intraatrial shunt because of therapeutic device, LA to RA. You can benefit the patients by reducing the left atrial pressure, left heart unloading, and improvement in heart failure symptoms. ASD, I think one of the commonest congenital heart diseases you will be encountering in your practice. Basically, you have to know whether what is the type of ASD and what effects it is causing on the heart, whether it is causing more than 1.5:1 shunt, what effects on the pulmonary circulation, what are the associated lesions, and what is the ventricle function, and whether this ASD is suitable for device or a surgical closure. So these are the basic points for us. I think this diagram summarizes all the types of ASD. As we have learned over a period of years, rims have to be adequate when the patient is being taken for device closure. At least 5 mm rims have to be there, and it should be thick rim, not a flimsy rim. That's how the patient will be taken a call to do a device closure or a surgical closure. And one of the other entities, what you find normally in infants, whenever you're doing your practice in probably a multi-specialty hospital, you will get a lot of references from the pediatric ward immediately after the birth. So they will be having, a lot of patients will be having some PDAs and then PFOs. So you should be knowing when to call PFO, what exactly does the PFO does, and what is an ASD. So you have this table to summarize. Basically, you should know, this is very common in around 25% of adults. I think rare in live births actually. Size is small, tunnel-like, this is often larger. Shunt direction is very important in differentiating PFO versus ASD. Shunt direction is usually right to left, but whereas in ASD it is left to right. QPQS is normal, here it is increased. Chambers are normal, there is no enlargement of RARV, here it is enlarged. And significance only if there is a stroke probably, then you try to go in and try to close the PFO, otherwise no. And then if there is symptomatic shunt is there, then you try to suggest closure for the ASD. Again, some more points to know ASD size. When do you call them small based on the size of the ASD? It's like 5 millimeter, it's called as A small. Large is more than 9 millimeter. In adults, it is around, again, small, medium, and large. More than 20 millimeter is large ASD. So you have to identify the type to summarize, then defect size, rims in multiple views, then color Doppler will help you to identify whether it is left to right shunt, any associated RB volume overload is there, and rim adequacy, more than 5 millimeters, if it is there, should be good one for device closure. Then check for associated lesions. And probably you can use trans-esophageal echo for adults with borderline anatomy. Whenever you have a doubt, probably you can bring in TE. QPQS, very commonly required entity. Whenever you have a shunt patient, you should be well versed with this. You calculate RVOT, LVOT, cross-sectional area, then VTI of RVOT and LVOT, then you come to a conclusion of what is the grade of shunt. And probably 3D echo, I think many of the hospitals have trans-esophageal echo, which has got capabilities to show 3D images. And then I think that will be a better assessment of a ASD for device closure. You have, I think, whenever you go to a cath lab to assist doctor, probably these are the views, we'll be getting them to show whether the device is in the right place. Then after the deployment of device, whether any residual shunt is there or not, whether it is impinging on AV walls, these all things can be seen by TE in the cath lab. Few words about primum atrial septal defect. It can be only OPSD or it can be having associated inlet VSD. Then this is sinus venosus ASD, usually goes along with PAPVR. Coming to VSD, VSD is one of the, again, commonest congenital heart disease probably after ASD. You have various types of VSDs. This diagram summarizes. Commonest will be perimembranous, wherein you find commonly aneurysm formation, then some attempted closure. They can have some associated aortic regurgitation. Next is muscular VSD, located in the trabecular septum, almost accounting for 20%. Spontaneous closure is very, very common here. Uncommon things are in VSDs or supracrystal VSDs, the spontaneous closure is very, very uncommon. But I think the percentage is very, very less. And then you have an inlet VSD where the closure is uncommon. This is a summary of multiple views which we try to employ whenever we are doing a child with a suspected VSD, starting from plaques, then going to the base short axis view, then short axis of LV at mitral wall, then papillary level, then 4-chamber view, then 5-chamber, then 3-chamber. So these will tell us where exactly is the location of VSD. And probably to simplify it, the yellow color is about membranous septum. So immediately just below the aortic wall, you have a VSD there. It's like perimembranous VSD. Then comes that outlet VSD, then the trabecular septum, muscular VSD. And then in this diagram, probably it's like a clock. Between 10 to 2, it's the perimembranous VSD. Between 12 to 2, first is it's a outlet VSD. Basically, it can be supracrystal and infracrystal. So again, to summarize, as in ASD, identify the location, whether it is suitable for device, what effects of the VSD is there on the heart actually, and then associated lesions, and estimate the QPQS shunt. These are some of the images to show the location of VSD. This is first one is perimembranous VSD, trying to assess the size and then going into that 5-chamber view. Then this is classical basal short axis view, showing a dropout in between 10 to 12 position, coming to a conclusion of perimembranous VSD. This is again plaques view, showing perimembranous and outlet VSDs. Some other examples, this is a classical LV short axis view, trying to identify muscular VSDs. PDAs, probably when you don't find anything in heart per se, and you have an enlargement of LALV, then I think you should be suspecting there is some shunt operating at the great artery level. So you have ruled out VSD, then I think your suspicion for PDA will be very, very high. There are multiple types of PDA, starting from silent PDA. When we examine them in the OPD, they don't have any murmur actually. Then very small PDA coming to large PDA, more than 5 millimeters, with a classical murmur of PDA, which is easily audible. The sizing is important. Based on the sizing, we can choose the type of treatment. I think probably this is an angiographic classification of PDA named by Krichenko, A to E. This is again important to identify what type of PDA is there, because A, B, C are very, probably we can take them up for device closure, and D and E are not very common types of PDA which can be amenable for device closure. So this is done in the cath lab. You can identify based on the morphology, this conical, window, tubular, complex, or elongated conical. Classical view for PDA is suprasternal or parasternal views. You have a high parasternal view also, and you can show the color flow from PA to listening alta. Few things you have to do in PDA. You have to measure the narrowest diameter, which is usually at the pulmonary end. Classify the type, whether it is A, B, C, which type of Krichenko, then try to identify the continuous flow. Looking for continuous flow in the listening alta, then assess the LV volume overload, then probably you can plan for whether it is PDA suitable for coil or ADO device. This is classical parasternal short axis view, also called as three-legged view, where you have RPA, LPA, and then thoracic alta. High parasternal view, you can probably try to get this. You have, first is RPA, LPA, then there is thoracic alta. This is called as three-leg view. You have a small PDA which is shunting torrentially from left to right. And one more example of restrictive PDA. Some of the images along with the Doppler in the main pulmonary artery, how if there is no PDA, the flow is like this. If there is a PDA, there is a torrential flow in the PA, forward flow. Probably these things are done basically to help in assessment of the PDA on the pulmonary circulation. So whenever there is a torrential flow into the PA, if the shunt is more than 1.5:1, you have large amount of flow happening here. Some of the modified suprasternal notch view, and then maybe this is Flax view, measurement of PDA size in the suprasternal notch view, again trying to identify the narrowest part of the PDA, which will help us in taking a further call about device or a coil. And whenever you have a patient with PAH, probably that is one more subset of patients when you are trying to do a echo, PDA with PH. Based on the flow only, you can suspect there is evidence of hypertension is there, whether it is causing any only left-right shunt, or is it causing bidirectional shunt, or is it causing a totally right-loop shunt. This is again suprasternal notch view showing multiple subtypes with the bidirectional shunt in the A, and then probably bidirectional shunt predominantly left to right. And in the C, you have again left to right shunt and color Doppler, and probably which is now commonly available in all the systems, color M mode showing left to right shunt. So plan of management in PDA usually are silent PDA, we don't close them. Very small PDAs, probably you can take a call on using some coils. Small PDAs, again, coils can be employed, maybe multiple coils may be required. Then moderate to large PDAs, ADO is the best one. A device at least 2 millimeter larger than the minimal ductal diameter should be selected. So again, going to the basic point, you have to help probably the doctor in the system to come to a conclusion whether the device is suitable for this patient or it is not suitable, or a surgical intervention is the best choice here. So if you can tell us about all these points, what is the narrowest diameter, what is the length of PDA, what effects it is causing, then the doctor can be better placed to take a call on the further management. Based on shape of the PDA, as we discussed earlier, Krichenko, ABC are probably best amenable for device. I'll be going through one or two congenital heart diseases which are like commonly seen across our area in cyanotic category. That is tetralogy fallow, contains, I think you all know this, VSD, overriding of aorta, infundibular pulmonary stenosis, right ventricle hypertrophy. The basic embryological abnormality is, what is the basic abnormality here which will lead to tetralogy fallow? What is the basic embryological problem here which will lead to VSD and pulmonary stenosis? Basically, there are two only important entities in tetralogy failure. All other things are secondary effects. No,
Anyone, please
infundibular-
tell. Students have to answer this, yeah. What leads to it? What is the embryological pathophysiology of TOF? Anyone? No, I mean, there is a large VSD. Sir is asking what causes this? Actually, there is a term called monology. So only one thing causes all the four. What is that? Any one person? Anyone? Something about the septum. What about it?
Movement of the septum.
Huh? Yeah, go on. Tell. Please tell, it's okay. Malaligned septum. Sorry.
No, superior and caudal movement of the infundibular septum, which will lead to
Superior.
malaligned VSD, then probably leading to infundibular pulmonary stenosis. So these are the two important pathophysiological features of tetralogy fallow. The other effects are all secondary. Whenever there is a movement of the septum, it will cause pulmonary stenosis. That will lead in turn to right ventricular hypertrophy. And because of the malaligned VSD, there is an overriding of aorta. So you have to remember that there are only two important entities which are basic to tetralogy fallow. One is VSD, the other is PS. In tetralogy fallow, I think the main crux is whether the child is suitable for total correction, probably meaning VSD closure and opening of the RVOT, which is called as intracardiac repair, or whether the child is not suitable for total correction, when then he will need some palliative shunt. So to know about that, you have to measure the pulmonary artery size properly, see for the confluence, whether the multiple entities are there to help us in knowing whether the PS have grown up correctly or not. Starting from simple Megun ratio, which will you have, I think, probably measure, you do it regularly, diameter of LPA, RPA before the branching, divided by diameter of abdominal aorta at the diaphragm level. So if it is more than, normal is more than 2.1. If it is more than 1.6, the anatomy is suitable for total correction. If it is less than 1.6, then the child is not suitable for total correction. He has to undergo some palliative shunt operation, maybe modified BT or a BT Glenn or a central shunt. So this is very, very important in tetralogy fallow echo. Apart from identifying the VSD, the level of RVOT obstruction, the presence of coronary abnormalities, and the size of the PS. So like Megun ratio, there are some other entities which will give us an idea about the adequacy of the PA. Nakata index, more than 160, I think, is adequate. More than 100, it is acceptable. And there is one more entity called as total neopulmonary artery index. So this also will be measuring the cross-sectional area of LPA, RPA, but it is indexed to body surface area. So these are all done routinely in cath lab also. When we do an angiography for tetralogy fallow patients, we try to give them the summary of size of the PS based on this indices. So you should be remembering about these things. In your echo also, you can bring in Megun ratio. Few words about Z-score. I think many of the books probably mention the Z-score actually, especially when you're doing pediatric echoes. It's basically measuring the pulmonary wall annulus size in reference to a reference population. So you have measured the child's pulmonary wall annulus, and that is being compared to a reference standard. So based on the height, body weight, and other factors. So -2 or less, probably pulmonary annulus that is significantly smaller than expected for the patient size. So you will be requiring a transannular patch. Z-score comes in all areas, starting from LA size, LV size, PA sizes, and then across all the measurements in an echo. Actually. So you should be knowing more about Z-score. This is only in relation to tetralogy fallow. So starting from parasol short axis view and apical four-chamber view, you assess MPA, RPA, LPA sizes. You identify the VSD, which is mal-aligned, then overloading of aorta, RVOT obstruction, RVH. Then probably you should be measuring what degree of aortic override. I think we have it in the cath lab. How do we know that? And assess the RVOT obstruction level and severity, assess the main and branch PAs, then probably bring in some Z-score, screen for MAPCAS. Aortic override, one of the concepts here was probably you try to measure the aortic diameter over the RV. How much of the aorta is over the RV? That is the aortic override actually. So divided by total aortic diameter. You measure inner edge to inner edge aortic diameter and you try to measure what is the aorta above the RV into 100. So this will give you a typical top. This is commonly 50%. So this is one of the formulas to assess the aortic override. Then best views are plaques view, subcostal long axis view. Then timing is systole. Normally 100% aorta will come from LV, but in TOF it will be 50%. In DORV, it is more than 50%, 1.5 arteries. So key findings are large mal-aligned VSD, and you have in tetralogy fallow, aortometrial continuity is present. So this is a plaques view trying to show you the basic anatomy of overloading of aorta, VSD. This is a trans-esophageal image, not a common entity to do because many of the patients, what we get is quite young and then in younger age group. So we don't do commonly TE, but I think you should know what exactly TE can help us. So you can assess again the aortic override, then probably ventricle function and location of VSDs. This is a slide to show you post-operative echo in a TOF patients. Many of the patients who have underwent TOF repair in childhood, they come back to you for a follow-up. So in those patients, you will have to assess properly the ventricle function, systolic function, diastolic function, then presence of TR, and then presence of pulmonary regurgitation, RV volumes, end systolic and end diastolic volumes. Based on that only, they will take a further call whether to do a replacement for pulmonary wall or no replacement. So these are some of the common things which we will be seeing in a post-operative patient. Apart from knowing the integrity of the patch, you will have to assess the systolic function of ventricles and the presence of PR and its effects on the RV volumes. So VSD patch to see for residual shunt, RVOT to see for residual obstruction. Pulmonary wall function has to be assessed for PR and then residual RVOT obstruction. RV size for the RV volume overload, then pulmonary artery for the flow and diameter, aortic root for the size, and LV function for based on the contractility. DORV, presence of aortometrial discontinuity along with VSD, overloading of aorta will go in favor of DORV. So you have to visualize the VSD, assess the relationship of great arteries, identify the outflow obstructions at what level, identify the AV wall anomalies, ventricle function, then associated anomalies. Multiple views will help you, again 5C and then subcostal views to evaluate all these things. One of the important things is whether the VSD is routable or not routable. So normally when it is being done, DORV echo, you have to identify the location of VSD, and whether that VSD can be routed to the aorta or not has to be opined. You'll pick up on the way. This is not the day one echo. You can pick up all these things. So you have to give us some idea when the surgeon will come and ask you whether the VSD is routable or not routable. So based on the location, if it is a classical subaortic VSD, it is manageable. If it is remotely located VSD, it may not be routable. I'll skip some of the just a word about TGA. It is ventriculoarterial discordance. They come in quite sick status to the echo room. You will have to identify whether it is TGA or NRGA. Then identify the associated problems like presence of ASD, VSD, PDA, then size of the ventricles. And then if you are able to identify the origin of coronary arteries, it will be good. So summarizing the normal anatomy, DTGA, LTGA. DTGA, some important features are like you try to confirm the AV and VA discordance. VA discordance basically, and then PA, whether it is parallel grid arteries or it is a crossing arteries, then probably where exactly is the intracirculatory mixing happening via ASD, PDA, and LV function and size and the mass for eligibility for switch operation. So you can concentrate on these points, probably then tell us about whether you can help in cath lab about regarding this bilateral septostomy also. And in a post-operative patient, you have to identify the coronary origin, LV function, and aortic wall. These are some of the important things. May not be all inclusive. This is the classical case of DTGA, LV giving rise to PA. How you are able to say it is PA? Because it is bifurcating. Then the other grid artery which is coming from RV is aorta. You're trying to show the bifurcation here. These are still images, again trying to concentrate on the post-operative patient who has come to the echo. 2 words about pulmonary venous baffle and then systemic venous baffle. Whenever the sendings is done, you will have to see on these points. Do not be worried about the complexity, but I think you remember about these terms. So you will read and probably learn about these things. So you'll have to identify, make a note of LVRU function, then see the size of the ventricles, then see the patency of the pulmonary venous baffle and the systemic venous baffle. So these probably points will help you to say whether the circuits are working correctly or not. This is an LTGA, atrioventricular discordance and ventricular arterial discordance. LA is connected to right ventricle because the AV wall is more towards the apex. There is an associated mild absence anomaly of the left AV wall. Then you have on the right side, right atrium connecting through the metal wall to the left ventricle. So I'll skip this. No, some of the diagrams where we were discussing about pulmonary venous baffle and systemic venous baffle. So probably this is kind of a summarizing the basic use of echo here. In AST, you can tell us about the rims and then we can take a call on device. VSD also, whether it is suitable for device or surgery. Then PDA, again for device or surgery. Tetralogy fellow, whether it is intracardiac repair or a palliative shunt. Then DORV, again, the surgical approach can be decided based on the echo. And DTGA, many of the times you will be doing only echo and then taking a call to do a further intervention. So some tips are like subcostal view is the best one in neonates. You can complete your echo in subcostal view, starting from identifying the situs, then orientation of the heart, then evaluating atrial septum, ventricular septum, then evaluating the right ventricular outflow tract, then ventricular function also. So you can wrap the echo in subcostal echo view if you have a good window, especially in neonates. Record 2D color Doppler and then continuous Doppler. Use a bubble study only if it is needed. You should be imaging Rs and the PAs carefully to know the associated malformations. To conclude, probably echo is very important and forms a cornerstone for diagnosis and intervention in managing congenital heart disease. Systemic segmental approach is very, very important. And then you should be having high quality imaging, which will definitely improve the outcomes. Thank you.
Thank you, Vijay Sai, sir, for a wonderful and concise, crisp roundup of the congenital heart disease. There is a lot more, as sir was saying. This is just the scratch of the tip of the iceberg, not even the tip. But then I think, as sir said, if we go segmentally, if we go chamber by chamber, I think, sir, that really forms the key to. That doesn't change, however complex the CT. So on behalf of students and all of us, sir, thank you again for the wonderful talks. Thank you, sir.
Thank you.
What is PAH? What is PAH? How much do you call PAH? Talk on. So, PA pressure of more than, come here, yeah, 20. Correct. So, its PAH is actually more than 20 millimeters of mercury. It used to be 25 earlier. The basic point that you should understand when we talk about PAH is you have the lung, right, which is in PAH terms called capillary. Anything before it is called precapillary. What sir was alluding to, Vijay Sai sir. There is an AHD. Flow is LA to RA to RV to PA. Then goes into the lung. So it is precapillary. You understand this? There can be something which starts after the lung and backward affects it, which is typically a left heart disease, mitral stenosis, LV dysfunction. LV pressure is high, LA pressure is high, back pressure on the pulmonary vein, back pressure on the capillary. This started after the lung, correct? So this would be called post-capillary. Whenever you have pre-capillary, typically, there will be a term called PVR, which is pulmonary vascular resistance, is more than 2 Wood units. It's called Wood units. If you're talking in terms of post-capillary, right? LV is affected, LA is affected, goes back. Obviously, you can't put a catheter on the left side and go into the LV and try. What else do? You put a catheter on the right, but you go into the wedge position. It's called as a wedge catheter, correct? So when you do that, you get a wedge pressure. So the wedge pressure is more than 15. So anything to do with precapillary is a PVR phenomenon. Anything to do with post-capillary is a pulmonary capillary wedge position phenomenon. Pulmonary capillary wedge pressure phenomenon. Anything which is both is like both. So you have PVR also more than 2 and the wedge also more than 50. Is it understood? You have the lung in the center, precapillary, and then the post-capillary. That's all. That's my talk. Finished. That's all that is needed in echocardiography in PAH, if you understood it. Rest of all of this is mumbo jumbo. Did you understand this? Trust me, it takes a lifetime to understand it. I have tried to do this with 10 batches of my juniors. It's not understood very commonly. It sounds very easy when you say this, but when you apply it in real life, you need to understand exactly which level the PAH comes from. There can be 10 classifications of it, doesn't matter. But the effect of PAH is on the lung. From the lung is on the RV. So anything that you look at and you quantify PAH will be quantifying not really just the pressure, but the effect of that pressure. This is all that this whole talk is about. Okay. What is relevant, I will talk. What is not relevant, you can finish it in your books later on. Right? So in the exam, you will be given this mostly if you are on a bad day, if Shani is going on as a 10 marker. If Shani is not going on, 5 marker. If you're not at all Shani, if Guru is going on, 2 marker, but that will be strain in PAH and all that. Anyway, so this is 15. I've written here 15 because this is the older definition. This was put deliberately because this has changed. In 2023, they changed it to 20 for 2 reasons. How has this 25 and 20 come from? Anybody can tell me this? 5-star again. So, the normal LV and diastolic pressure is 8 to 12. There is something that needs to draw the blood across the lung from the right. That's called as a transpulmonary gradient, which is up to 12. Up to 12 is normal transfer. It's like an engine which drives the blood from RV to the lung to PA to back to the pulmonary vein and to the LA. This is 12. This is 8. 8 is the lower limit of the EDP, LV and diastolic pressure. 12 plus 8 is 20. That's it. Period. It used to be 8 to 12. You should take it as 12 and 12, 24 earlier. But they brought it down, taking the lower limit of the LV and diastolic pressure. That's why you made it 20. So it's not 25, it's 20. And PVR was 3 earlier. I have deliberately put this slide as the earlier one because this came from what was called as a Dana Point classification, which I'll come to later, Dana Point conference. But now it is 2 Wood units. So there is a lot of stuff to understand, but then this is easy to understand it in terms of what I spoke to you. There are 5 classes. One is where it is idiopathic pH, where it is the left-sided heart disease, where it is CTE pH, unknown causes, etc. But this is how it's the best understood. You don't need to mug up. You need to understand it. Number one is PAH, pulmonary arterial hypertension, where the artery itself was the problem, precapillary, right? There was a problem in the in the lung, in the capillaries proximal to the lung. So it's precapillary. Second is coming from the left side. That means the LVEDP was raised, the LA was raised. And why I say it's difficult to understand it for a lifetime, I'll tell you. There is something called as a pulmonary artery hemodynamic continuum. If you understand, LVEDP is the same as LA pressure, is the same as pulmonary venous pressure, almost the same, almost as PA end diastolic pressure. You see, it entirely follows one line. It's the chain of flow from one chamber or a vessel to another. Correct. So when you see that, the only thing is you need to be 2 more on the right side because something has to push the blood across to the left. That's all. So when you associate it with lung disease, that can be the problem causing PH. There can be pulmonary arterial obstruction, like for example, if there pulmonary embolism or a small vessel obstruction, that can lead to PAH, and unclear or multifactorial etiologies that can lead to PAH. So at what level you are trying to segregate it and say, for example, in a cardiac cath done for an AHD. I'll come back to that. It's the simplest way you can understand it. Again, the shunt is LA to RA to RV to PA. The shunt kept flowing, and then the pulmonary artery kept on feeding more blood into the lungs. Eventually, PH developed. Difficult to understand? No, this is precapillary PH, correct? So this goes to a certain extent where the shunt is still left to right, then the lung pressure starts to rise. It won't allow the PA to empty easily. The pressure shows up on the RV, right? That means the RVSP starts to rise. At some point in time, the pressure starts to build up so much, the AHD is still there, the shunt reverses. This is called Eisenmengerization. Correct. So this is the sum total of trying to understand how PAH behaves as life progresses. At what point in time? Because this is precapillary. Now, if I want to do a cath, why am I doing a cath? My point is, if I close this ASD now, at whatever point in time, is the RV using it as, you have a word there called pop-off. Is it using it as a valve? Is it that the RA is now emptying into the LA through the AHD? You close that, the RV will fail because it was using the AHD to shunt across. Correct? That's the reason why Eisenmengerization should not go for surgery. Because if you close that AHD, it's gone so long in time that now if you close it, there will be a RV failure. The same thing applies for VHD, the same thing applies for PDA, all of them. When you have a left to right shunt, which is flowing left to right, and eventually the pH becomes so much that the shunt becomes bidirectional. Okay, and you close it, and there is, there is a need for that shunt to be preserved because of life at the cost of desaturation. Now you close it, the RV will go. So you need to tell the surgeon, when we do a cath, we need to tell the surgeon, are we safe to close it or not? That's important. Typical echo features here, right? You can see that the septum is bowing, right? It is bowing into the, see, usually you would have the LV pressure more than the RV pressure. But you see here, it's sort of moving like a paradoxical septum. It's moving both ways. Where's the pointer? This one, right? So you can see that this particular thing was actually moving this way, and that way. And if you see this septum, I'll play it again for you. If you see this, it was playing, right? Either way. So this is called as an eccentric septum. This septum will start bowing towards the RV, towards the LV. So this is so enlarged. In a PSAC's view, this is the RV. Why is the RV so much enlarged? See if you can get this running. So the point is, you will have to see, these are the most basic things that you see in a pH. You see that this starts to become paradoxical. The RV starts throwing it towards the LV, which should not be. That just means that the RV pressure is high. This becomes eccentric.
That means it becomes D-shaped. The septum is now bowing towards the LV rather than other way around. So this way. So you can see that this is now bowing down, right? It is called as a D-shaped septum. It's okay. Srinivas, it's fine. The second thing is the RV systolic pressure. You have a TR jet, you put your continuous wave Doppler there, and you get a complete envelope like this. These are enough pointers to tell you that this is a severe PAH case. What happened? We have a guideline directed approach. So basically it tells you that there is at what level you have, give me the, at what level you call it a severe, mild, moderate PAH. Anybody? See, more than 20 I said is abnormal, but then you have to grade it. How do you grade it? Anybody here? Simple questions, yeah, come on. That payasam was too much for them. You shouldn't have given them so much sugar. So 20 to 30, 21 to 30 is called mild pH, mean pressure. Mean pressure of more than 20, I said, right? So everything is in mean now. 21 to 30 is called mild, 31 to 40 is called moderate, more than 40 mean is called severe pH. Okay. So how all do we estimate the pH systolic pressure? The commonest things that you have always seen, you can do it from the TR velocity. You have a TR jet, I told you just put in this one. So you always know, it is the most common thing that we do. So we have a TR velocity, it's 4V square, correct? 4V square for that particular velocity. The second thing you can do is, you can take it, if you have a PR, if you have a pulmonary regurgitation, you can put it there as a continuous wave and Doppler, and you can estimate this. In this, what is this and this? Anybody? This is the loud, mean. So this is the PA mean, and this is the PA end diastolic pressure. So this is the PR jet. It's not always visible, or you can't capture it always, but generally congenital heart disease actually allows you to get such a nice jet. So you get a PA mean here and a PA end diastolic here. So that's one way you can do it. Two ways we have seen. One is RVSP, the second is PADP. Anybody? Any other way? Any other way? Any other way you can take the TR jet? The one I have shown you is this, right? In a 4-chamber. You can take it in an apical 2-chamber. I mean, sorry, in a PSAX view. So once you open up your tricuspid, like valve there, you can get the same TR velocity there. So you can do it in that view as well. And you can take it from PAT. Now, what is PAT? What is pulmonary acceleration time? It's basically, is it good to have it large or, high or low? Good to have it high, good. So that means if it accelerates, if it takes time to accelerate, it means there is no resistance for it. But if it accelerates very fast, within say 50 seconds, 50 milliseconds, then it means that the PA pressure is really high. So the general accepted formula is 90 minus half the PAT. Easy to remember this. There are many such formula. It's 85 minus 0.6 PAT and all in some books. 90 minus half of PAT. So if you see the pulmonary acceleration time, you should see it typically in a pulse wave Doppler. You would put it in the PA. You would put it somewhere here, right? And once you do that, you get a PAT. And then you look at what is the acceleration. It's like taking something akin to your ventricular actuation time in the ECG. How early does it accelerate? So it's the same thing. How early does this accelerate? So if it accelerates quick, 90 minus 60, half of 60 is 30. So PA mean is 60. Instead, if it is 120 milliseconds, so 90 minus half of 120 is 60, that is 30 milliseconds. So you have a higher PAT, it's safer than a lower PAT. So that's the third way that you can take the PA pressure. It's always important to look at the right side, like right side hemodynamics in terms of the RA pressure as well. Because you have to add that also to your eventual formula when you say RASP plus RA pressure. How do you know the RA pressure? Again, that has its own formula. So you know that in terms of IVC diameter and the sniff test that we do. It's something that you should do always. These are not just for exam purposes. It's really important because they work a lot in the ICU for patients, one. Secondly, they even work on patients on ventilator. There is a separate formula for that, but then you can describe this, that if the IVC diameter is not too big, if it's less than 21 mm, and if the collapse is good, that means your RA pressure is relatively good. Okay, so you have to add to that to your basic formula of 4V squared to get a RV systolic pressure. And of course, there are actually higher grades. The last one obviously is the worst. When your IVC is dilated and it doesn't collapse with sniff, it means that your RV pressure is high. IVC gives a wealth of information. Always remember this because when we were training, not just here, even in like our MBBS days, ma'am would agree. We used to always be told that a PA line is mandatory. Echo was not so much great in 1990s and 2000s, because it had not yet still percolated to as many centers as it is now. Now in 2000s, right? 2000s, I'm saying the first and second decade, PA pressure is already gone. PA catheter is almost gone out. Nobody puts in a PA line there and sits because it's invasive. You can always repeat an IVC every few hours, right? When you're managing a sick patient. So this gives a wealth of information. It's very easy to get. Try to practice it doing it in the subcostal way. It's always good to do it. And how much is it at baseline? How much is it at sniff? PVR is something I told you again, right? PVR is to do with the lung. So once the damage is to a certain grade, the PVR will be high. There's a very good correlation with the right heart cath and echo. So you should know to at least know to do a good echo and RVSP before you calculate the PVR. Very important is what is the pitfalls that all of our students have done these mistakes. Number one, understand that if you have severity of pH really, right, and the PASP, as the higher and higher grades go, really once you cross 50 and 60, it's not really that it goes linearly. It need not go linearly in life. Remember that because you have the lung already damaged. 80 to 100 may not really make a great difference to the patient, as in 80 is as bad as, for example, 100 is, right? Because people behave differently in lung differently. The second thing is PA pressure will decrease as, for example, the RV fails. We always keep thinking this. It's a flow-dependent phenomenon. Once the RV starts to fail, something like, your low flow, like low gradient AS. AS gradient will come down when the driving pressure is not great. Simple. Same thing. Once the RV starts to fail, right? Somebody gets an RVSP of 50 5 days back, 70 5 days back. And now the second tech comes and tells me, so the RVSP is 50. I don't need to rejoice all the time. RVSP may have come down because the RV is failing. It's RV systolic pressure. You have a systolic dysfunction. Simple. So you have to understand that you do these as flow-dependent phenomena. You should correlate them, how good or bad you've done. If you've done nothing between those 3 days and the RVSP of 90 has come to 30, I am not happy because the RV has failed. Understand? And I might actually do something like giving a dobutamine, for example. The RV might pick up and the RVSP might go up. That tells me that the RV can fight back. So serially seeing these things is important. Then on an average, they say always that PASP of more than 2/3 of your systemic means severe pH. That's just a rule of thumb. If there is, of course, there was something that sir also mentioned. We had Vijay Sai sir who mentioned about, there are two different etiologies. One is pH and one is PS. Don't ever confuse the two, right? I have students who write in exams TOEFL and then they write about PAH. We won't be giving any marks for that at all. It deserves a 0 because that is a PS physiology. Don't confuse PS and pH just because cyanosis is there. Cyanosis can be either cyanotic congenital heart disease is most likely PS physiology, pulmonic stenosis physiology, RVOTO, all whatever you'd call it. What I described to you as Eisenmenger is the extreme of PAH. Don't get the two in the same basket. It doesn't work. It's either PS or pH. So, especially in congenital heart disease, one has to be very careful because it completely goes on two opposite tracks. One is to be treated as PAH and one is PS. The PS patient is purely operable, maybe, but the PH Eisenmenger person is not. Correct? So, this makes it a case of life or death. It's like that. Always use a correct angle. This is something that all our teachers have taught us, and I keep telling our techs. You can at the most go with a cosine of 30. You can go in any echo. Remember this. Whenever your jet is not central, it's eccentric, you can at the most go to an angle of 20 to 30 because a cosine of that angle and more than that will not give you your correct interrogation. So if it is not, now of course we have angle corrects and all on the current Siemens machine, Philips machine, GE machines. We didn't have all this earlier, where you can actually change the angle of your interrogation and do it. So what typically happens in the OPD is the TR jet is like this, somebody keeps it like this. And then you wouldn't even get an envelope, and then you'd call it less PAH or whatever, mild PH. So well-defined borders of the TR jet, clean envelopes, please go with that, right? There is typically something called as chin and the beard. We have the Doppler signal, and then we have the outpouchings of it, which come down, which is actually a reflection of the higher velocities. Don't go with the beard, go with the chin. Don't go with that extreme depth, extreme lower point. I mean to say, do not go with here. This is not the pH. You have to go somewhere here, because the chin represents the actual RVSP rather than the beard. It's a way of just expressing it. Don't like in the exam. Don't please use these terms. Echo features of pH overall. I just put it. This is a slide. So RV size has to be seen. The RV systolic function has to be seen. TAPSE is something that you'll all see. That is tricuspid annular plane systolic excursion. RVH, which is normally less than 50 mm. 5 mm, sorry, the 5 mm of the septal of the free wall diameter, of the free wall thickness. D-shaped septum, I told you. Flattening of the septum in systole, diastole if there is a paradoxical movement. And of course, the hemodynamics, which I showed you all about, the RVSP, the PA mean, the PA ADP, all of that needs to be seen. Strain is something which has come up in a big way. All the current machines have mentioned it, because one must understand that the RV is quite commonly affected when the LV is affected, because your interdependent septum is there, which will cause both to get affected. So that is, for example, and the same way if you have vice versa. RV will affect if there's a septum bowing on the left, the LV filling will come down. So it's basically a biventricular thing that you should be trying to examine. Never forget that PAH has secondary features. This is the most common thing actually you and I will see in our practice, that PAH is coming from something else. Never forget, and this is very, very commonly happened. I wanted to mention this when Vijay Sai was actually speaking. When PAH happens, the PA pressure is high. Would you be able to see the shunt in a PDA? No. No, you will not see the shunt in a PDA. You will do the PSACs. You will see that you will put your normal 60 millimeters, 60 scale of your like Nyquist limit, see nothing there, and come out saying that there is no congenital heart disease. And time and again, and if you ask any congenital cardiac surgeon, he will tell you this. The minute they open the chest in a patient with PAH with VSD, for example, they look at the PDA first. It's the commonest thing that's missed, because these are color-dependent phenomena which go on pressures. If the pressure is almost the same in aorta and PA, how are you going to get a jet going from this to there? You can't. So always remember that congenital heart disease, missed congenital heart disease, is the commonest reason that somebody gets a secondary PAH. And again, this makes a life and death difference. If the child is not picked up with a PDA PAH and somebody labels him as idiopathic PAH, it goes on as idiopathic PAH all along until the time that somebody picks up PDA, and by that time he would have probably Eisenmingerized. Am I like overshooting? No. Okay, we'll have one more talk after this, ma'am. That's why. Yeah. So this is the last thing I wanted to tell you. Please read about this classification. Right? This is PAH group 1 versus group 3. Group 1 is what is called as if you have idiopathic PH. Group 2 is typically when we have a left heart disease. 3 is when we have lung disease or if there is a hypoxemia. 4 is CTE-PH, I told you, chronic thromboembolic, and 5th is multifactorial. You don't need to know this. So if you want to define prognosis, you look at all of this, which is difficult to take only today with an echo, but at least the ones which I have told you about, TAPSE, RV index, the RVSP, PADP, those can be taken into account. PH is common. Number 1, mortal if it's missed. Always, I keep on saying this because we have seen a lot of cases. As a resident, I have missed it. My seniors have. I was taught about this because we were not having as good machines as you are actually having. Because we used to have the Sonos machines in all of earlier times. So we wouldn't get that clarity sometimes. But it's simple. Get the scale down on your Nyquist. You will start seeing that flow. So it's a very commonly missed AP window or PDA as the age may be. The relevant background is important. Never do a PAH study without knowing the clinical background. And understand the types which are made, all the measurements, at least the basic ones which you can take as your, as a basic index of PAH. Understand them by the term which they get and by the clinical background which they come from. And it's generally a wrong measurement that leads to a wrong diagnosis always. Because if you do not align your Doppler interrogation jet properly and do that, that's when it gets missed. Thank you. Ma'am, how about the SVT talk? Should we have it now or? Rahul will continue and then we will have the Angio 3 talks. Can I just finish the SVT talk now? Sorry? Okay, Rahul, you have, is he here? Okay. We'll continue the intervention after this, Jesse. Sure, we'll do that. Because this will set the tone for it. Okay.
So, good afternoon.
I told you the payasam was too much on them. Next time we'll skip the payasam, I think. We'll keep some pickles, 2-3 pickles we'll keep extra. Go ahead.
So, good afternoon. Today I'll be.
This is something which you will be asked in exams for sure. Sorry, Rahul, just a second. You cannot go for exams not knowing angiography, for sure.
Yes. Yeah. I'll be discussing these points. Coming to basic first anatomy, the left main coronary artery divides. There are two arteries. First thing, left main and RCA. The left main originates from left sinus of Valsalva and divides into LAD and L6. Occasionally, you might get a third branch known as ramus intermedius. The LAD runs along the interventricular sulcus and gives rise to septals, which supplies anterior 2/3 of interventricular septum. And it also gives rise to diagonals, which supply anterior and anterolateral part of LV. The circumflex, which courses along left AV groove and provides branches for LA, and occasionally in around 40% give rise to SA nodal artery. So, circumflex also supplies LV lateral and posterior wall with the branches called obtuse marginals. The RCA courses along right AV groove, which give rise to, there are three parts, proximal, mid and distal. Proximal RCA give rise to RA branches, conus and SA nodal artery. And at acute margin, it gives rise to acute marginal branch which supplies RV, and at crux, it divides into PDA and PLV. So as you can see this, as you can see this LAD and circumflex coming from LMCA, which course along interventricular septum, and RCA, which course along right AV groove. So 2 points we have to understand. First thing is interventricular groove, which is present anteriorly. Whenever you take a LA angulation, the interventricular groove is seen as en-fas. However, AV groove seen as orthogonal plane. And in case of RA angulation, you can see AV groove is seen as en-fas, and interventricular groove is seen as an orthogonal plane. So coming to first descriptions of each arteries, we divide LA into proximal, mid and distal, and likewise we divide circumflex into proximal, distal, and we divide RC into three parts. What is proximal artery? What is proximal LAD? It is from ostium till first major septal branch. As you can see this here, it's a proximal LAD. What is mid LAD? It's immediately distal to origin of first septal branch and extend to point where LAD forms a bend in RA coronal view. And if this angle is not visible, and this segment ends at one half of a distance from first septal to apex, this first half. And distal LAD is terminal portion, that is beginning of previous segment and extending beyond apex. And along this LED, you can get septal branches as well as diagonal branches. Diagonal branches, as I told, supply lateral wall. And circumflex, we have two divisions, proximal and distal. Proximal, uh, it's from origin till major OM. This is proximal L6. Distal L6 is stem of circumflex distal to origin of most distal OM and running along posterior interventricular groove. Sometimes it may be in small caliber or it can be absent. You may have OM branches from OM 1 to 3, depending upon numbers. Sometimes you may, in case of left dominant artery, circumflex and PDA arrays from left circumflex. Coming to RC classification. Proximal RC is from ostium to 1/2 of distance to acute margin. Mid RC is from end of first segment to acute margin of the artery. And distal is from acute margin to PDA. PDA is the one which is seen in posterior interventricular septum, which supplies around posterior 1/3 of the interventricular septum. And PL, it arises from distal RCA and it gives rise to AV node, it gives rise to AV nodal artery. So coming to after clinical anatomy, we'll well into coronary angiogram. Why do we do angiogram first? To confirm the presence and nature, or in some cases, to dismiss the clinical diagnosis of CAD, and to assess the location and extent of luminous stenosis. And it also helps to decide upon therapeutic strategy. If it's more significant, more than 70%, we may have to revascularize, or if it is less than 60, we may have to put on medical treatment. So coming to basics of fluoroscopy, it's just an X-ray with the angulations, cranial and caudal, or LAO or RAO angulations. As you can see, this C-arm has two parts. One is source, that is X-ray generator, and one is image intensifier, which captures the rays coming from generator. Just an like a camera capturing images from generator. As I told you, it's angiogram is basically X-ray with cranial and caudal and RAO and LO angulation. So how do you take this? We cannot take randomly. So in left, there are around first, how do you take left side shots? First, we hook a left main artery in epicaudal if you're taking from femoral axis, and we first go with RA caudal, RA of angle of 50 to 30 degree and caudal of 10 to 30 degree. Here we measure proximal parts, proximal LAD, proximal circumflex, and distal LMCA. And next we go to RA cranial. Here we measure mid and distal parts of LAD. And next we go to LA cranial. Here we see mid and distal LAD. And in case of left dominant, we can also see circumflex. And in LA caudal, which is famously known as spider projection, you can see the proximal LMCA and its trifurcation or bifurcation. Coming to our right side shots, it can be taken in LAO 45, LA 30-30, or RAO 30. LA 45, it helps to engage the RC ostium, and here we can assess ostium and RC along AV sulcus, and LA 30, it will visualize PDA, PL, and RC after crux. However, RAO 30, it helps to visualize PDA ostium and PDA septal branches. So coming to how do you tell RAO or LAO or cranial caudal? First thing is you should be able to differentiate whether it's caudal or cranial. If it's just a pictorial representation, whenever you see a diaphragm, it's a cranial, and whenever we don't see diaphragm, it's a caudal wave. And in case of just remember one more thing. In LA projection, the image intensifier, which captures the image from X-ray, it will be on left side of the patient. However, on fluoroscopy, it will be right side of the screen. In RAO, it's ulta. That is, the patient will be on the right side of the image intensifier will be right side of the patient, and spine will be on the left side. As you can see, this the spine is present on left side of the screen. So it's RAO, and we see the diaphragm, it's RAO cranial wave. Just a, can anyone tell me what wave is? You can see a spine on the right side, and you don't see diaphragm. So RAO cranial wave. Likewise, here again, you can see a spine or ascending part of the catheter on the left side, and we don't see diaphragm. It's again RAO cord. So in case of RAO, as I told you previously, it looks at AV groove. However, LAO looks at ventricular septum. So one basic rule is for cranials, we should always look for LAD, and for caudals, we look for L6. And cranials, we measure mid and distal segments. In caudal, we see proximal segments. And whenever we do angiography, there is something called foreshortening, and to avoid it, we have to do orthogonal to it. What is foreshortening? Whenever you take an image along the line of the artery, sometimes it might get missed, lesions might get missed, or it may be foreshortened. So to avoid it, we have to take perpendicular to that artery, so that segment is laid out fully expanded and lesion is not missed. So coming to standard positions, this is a patient lying on the table. This is a cranial end. This is foot end, and this is left side, right side. Starting from left side injection, we'll take from RA caudal. The image intensifier will be in the right side of the patient, and it will be near foot end. And if the image intensifier is present lateral to it, only present right side of the patient without any angulation, it's RAO. And if the image intensifier is present along right side of the patient and it is near head end, it is RAO cranial. In the same way, you can see LAO cranial, LA caudal, and LAO pulse. And image intensifier present directly above the head or foot end, it can call epicranial, epicaudal. Remember, it's always with respect to the position of capturing image, that is imaging intensifier, not source. So can anyone tell me what's the view here? This is basically we are trying to hook a left main. You can see ascending catheter and spine on the center, and we're trying to hook a left main. It's apical. What's the view? You can see a spine on the right side, LAO, and you don't see LAO 45. So you should know some terminologies. Straight, whenever we don't mention cranial or caudal, it is understood as straight, just RAO or LAO. What is steep and shallow angle? Shallow angle is whenever degree is less than 60 is shallow and more than 60 is steep. So coming to first left side injection, how do you see left sides? Can anyone tell me what to use? Again, see the position of the spine or ascending catheter. It is present on the left side of the screen, RAO, and you don't see diaphragm. So it's caudal wave. Sometimes diaphragm may be confusing. Then you should go along. You should always remember circumflex. Circumflex always goes with the image intensifier. Circumflex can be seen here caudally. So it's a RA caudal view. You can see circumflex, LAD. In this view, LAD and diagonals can be superimposed. So RA caudal view is as I told you, caudal views are best for proximal. It is proximal LAD, proximal circ, and even distal LMCA. However, they are not good for mid LAD due to overlap of diagonals and septals. The same thing, RA caudal, patient lying on the table, image intensifier on the right side and near foot end of the table, and you can see LED and circumflex. This is a schematic representation. LMC divided into LED and circumflex. Circumflex showing marginals. So to open, sometimes we may have to do a more caudal angulation so that you can see a bifurcation of LED and L6. So RA caudal for mainly proximal LED, proximal circumflex, and distal LMC. Next, coming to RA cranial. Which is, can anyone tell me? Again, catheter, ascending catheter on the left side, and there is diaphragm. So areocranial. Areocranial is best for LED and diagonal branches. The same thing, patient lying on the table, the image intensifier on the right side and towards the head of the patient. Coming to aleocranial. As you can see this, it's the best way for imaging ostium of left main and origin of diagonals. It's just present along the spine. Sometimes it so happens that the LED proximal segment can have foreshortening. So in that, we may have to take epicranial. In aleocranial, you also see something called if there is dominant circ, we see LPDA arising from circumflex. So the more LO will bring LED away from the since in aleocranial this LED will be along the spine. To bring it out, we have to go more LAO, and more cranial will show bifurcation of left main. Coming to epicranial, as I told you, the image intensifier will be on the head, at the head end of the patient. Can anyone tell me what view is this?
Call it spider. Don't call it spider. Tell what the view is. It looks like a spider. Aleocaudal, yes. Always tell the, it's called a spider colloquially. Yeah, go ahead.
It is called spider because of its branching pattern. You can see distal MC divided into circumflex and LED giving rise to diagonals and septum, septal arteries. It's the best way for left main and bifurcation, and even proximal LED also. So this is how LA caudal looks in, if you say 3D imaging. LA will be coming down, LB up, and RB along that side of the image. So LA caudal, it's best for left main, proximal LED, circ, and ramus if it is present. Same thing, LA caudal, the image intensifier will be on the left side of the patient, and it's towards the foot end of the patient. You can see LM left main divided into circumflex, LED, and LED giving rise to diagonal and septal branches. And sometimes you may have a ramus intermediaries. Coming to sometimes we take lateral views. It basically separates LED and L6, and useful in especially in case of LED occluded LED. And in left lateral, LED is seen on left side, and right lateral L6 is seen on left side. This is a lateral view with circumflex and LED. Here it shows the mid LED and circumflex arteries. So as you move cranial, if you compare all three cranials, the LED moves to opposite. Coming to RCA, as you see, RCA arises from right sinus of valsalva, and it descends along the anterior ABV groove, and it goes along the posterior interventricular groove and gives rise to PDA, which supplies inferior posterior 1/3 of interventricular septum. So mainly we use three positions. One is LA for, engagement of RC ostium. As you can see, engagement of RC ostium, and we can assess the artery from properly from ostium till mid RCA. In case of LO 30-30, you can see bifurcation of PDA and PLBs in distal RCA, and sometimes we take RAO just to see mid RCA. And what is dominance of the artery? Whichever the vessel which supplies the PDA, it is called dominant. In case of right PDA, the PDA is arising from RCA and it supplies the septum, which is posterior 1/3 of intermedial septum. And left dominant, it is coming from circumflex. Sometimes we might have a balanced. Just not only we use not only to see the coronaries, we can. It's a LV angio showing the pigtail catheter in RO 30. You can see the pigtail in the mid LV.
So here you could be asked, if you are not, again, if 7.5 Shani is going on, go back. What are the segments of the LV? Anybody can tell? See, these are things asked which are generally, if you're doing well. Stand, it's okay. Give this thing, marker. So this is an LV angio. Okay, this is done in the RAO projection. It's looking into the LV. So this is the anterobasal, anterolateral, apical, inferobasal, diaphragmatic. Okay, it sits on the diaphragm. So they'll ask you the segments in an LV angio. This was asked in NH a few years back, exam, in the finals.
As sir discussed, these are the segments: anterobasal, anterior.
Oh, you're showing them? Sorry, I interjected. I didn't know you were showing. Sorry, yeah.
Inferior and inferior basal. In case of LO, you can see basal, lateral part, apical, and septal part.
The inferior is also called as a diaphragmatic. It sits on the diaphragm, so inferobasal and diaphragmatic.
And coming to last, what are the pitfalls of the coronary angiogram? It is just a luminal angiogram, which is projecting 3D into 2D images. Sometimes it might give incomplete information. There are so many failures, like having a superimposition, foreshortening, and angulation and looping of the vessels, which cannot be properly assessed. And in case of poor and inhomogeneous filling of vessels due to inadequate force of injection, can give us to poor results.
Thank you. Thanks. So I'll just give a brief, a very nice talk, Rahul, but I'll just tell you, what I would want you to do is, you people can sit there and help us with that, right? Let's see how much we can help you out. Whenever, okay, how many of you do angiograms, assisted angiograms? All of you, correct? All of you, yes or no? You are going to assist, at least some of you will go into invasive, right? There is a sequence in which he spoke. Let me just take a show of hands and because you are from like all are not from one institute. Which is the first angiographic view that you take in your institutes? Anybody? Right or wrong, doesn't matter. The first angiographic, this left system catheter goes in. What does your cardiologist tell you to do? Huh? No. Plain LAO. No, it's always a caudal view. Always remember that. There is a sequence. The sequence is, you want to look at the left main, LAD, LCX. That's how angiogram goes, right? And then you look at individual vessels. Understand it here and now. You should not make this mistake again, okay? You've all sat till the end. Please take some advantage out of that. Number one, you should know the correct sequence of your angiogram. Nobody does a plane. You have to do a caudal always, because let's take his, it's not getting switched. Let's take his talk. If you take this view, the RAO caudal or the LAO caudal, see what happens here, right? This is actually more important for you than the talk of intervention. At least you should know all of this. So what happens with this is, what is your scare? You have taken this for a coronary artery disease. What is your scare? What are you scared about? Proximal disease. Obviously, you're worried about left main disease, proximal LAD disease, proximal circ disease. Correct? This is a talk for everybody, my techs, my juniors, all of you. Always understand this. Keep this as a standard way of doing an angiogram. Number one, take a caudal view. The caudal view shows you the left main, LAD, LCX, proximal segments, clean and clear. Right? This should be the first view that you take in an angiogram. AP caudal is fine, or an LO caudal is also fine. But it has to be a caudal view. Look at this again. It shows you left main, LAD, LCX. Correct? The caudal views show you the proximals better. Cranial views show you the mid and distal better. One statement. Caudal views show you the circ better, LCX better. Cranial views tend to show you the mid and distal LAD better. Now, take this in your mind and then go ahead. The first view should be an RAO caudal or an AP caudal, where you're cleanly seeing your proximals and you know that something is wrong here or not. Number one, it tells you proximals are involved or not. Number two, it tells you how much you can shoot more. Supposing there's a left main disease itself, why would you want to take any more shots? Each time you take a shot, remember that your contrast is replacing blood. That's why you're getting black, right? Blood is not black. How does this whole black thing come? It's contrast. So each time you shoot, you are replacing blood with contrast. You will cause more and more ischemia. That's why take an LAO caudal or an RAO caudal or an AP caudal, as the situation may be, make a call and decide, are you going to go ahead or not? Sometimes you don't need anything else. Sometimes you should not go ahead. That's the point. Let's assume that you have seen this. You know nothing great is wrong with the proximals. Then I want to see one by one artery. I want to see the LAD first. Obviously, LAD is the more important of the two, right? I go to the cranial. Now, when I go to the cranial, I see the LAD in its entirety. Okay, I'm not seeing the left main. I've already finished seeing it. I don't need the circ on this. I've already finished seeing it. So now my intent is to see the LAD. I'll see it better. I'll take a cranial view. That's the point. There is a sequence, there is a science behind it. It's not random. You have seen the caudals, you have seen the proximal LMCA, proximal LAD, proximal circ, right? Now see one artery. You see the cranial. You see this, it opens up well. Versus this, which sort of foreshortens it. You see this, you are able to see it here also, the LAD. But it's not as, it's sort of foreshortened. This is called foreshortening. I hold the same pen this way, and I see this way, and I see this way. It looks short in one view. That's called eccentricity. The heart is, it's not straight. That's why it's actually positioned like that. So your second view has to be areocranial, this one. Because it sees its LAD in its entirety. You have seen the proximals anyway. Here again, you're seeing the mid and distal. This has to be your second view. You should know your numbers well. Areocaudal is 25, 25. This is 9, 9, 40, 9 to 10, 9 to 15, 40, whatever. Areo 9, cranial 15 to 40. So now you have finished seeing the LAD, right? Now you know that your LM is normal. Let's assume LM is normal, LAD is normal. Now I want to see the LCX. I just told you something. What did I tell you? It is better seen in caudal. LCX is seen better in always caudal. Now I go to LAO caudal. And I see the LAD has been seen already. Now I am seeing the LCX in its entirety. So this has to be my third view. I finished. Come again. Areocaudal, areocranial, LAocaudal. I don't need anything else. That's it. Nobody tells you that the number of shots you increase is going to make you understand more if the first three have not got something in your head. By now, you should be clear. Your left main is affected or not, your LAD is affected or not, your circ is affected or not. Why do you need anything more? Right? Now, he was talking about dominance. Actually, you can make the dominance out till now. But if you really do not understand it till now, then comes the LAocranial. This is your LAocranial. Actually, he's written the foreshortening part very well. You look at this. This is such a long disease. if you see really in terms of centimeters of that vessel, it's the same affected here, but it looks so short here. That's why ileocranial is not a great shot. But what it tells you is the circ giving you a branch here, which is the LPDA, if at all. That means if the left is dominant, LED will run in the anti-interventricular groove, LPDA will run in the posterior interventricular groove. Now that is what is called as left dominant. But it's not just the dominance that's important. There are other things also. Like for example, allocranial is taken more. If I want to see, you see in this, there is nothing which is coming down here. So this is not left dominant. This is right dominant, right? The thing is, if I shoot this, I know my right has to be dominant. I have not yet done the right, correct? I have done only RAO caudal, RAO cranial, LAO caudal. When I do this shot, it tells me that my left is not dominant. It's for that thing it is done. And it is also done because your LED may fill the RCA if there is an occlusion of the RCA. So it has it has its importance in life. Otherwise, you do not need to do it. If the patient doesn't have an inferior wall MI, RCA you're not expecting to be occluding, you don't need this shot, because I'm going to do this to see whether I can see the RCA from the left. That is the reason. It's like a double jump thing. Otherwise, 3 shots tell you that's enough. Same thing about the right. Whenever you have to see anything, for example, if I have to see this, I have to go opposite to that and see. If I have to see the right, I have to hook in the left anterior oblique, because I can see the ostium very clearly there. You can't see parallel to the ostium, correct? So I take a left anterior oblique, LAO 30 as my first shot of the right. So which shot is that? This one. Correct, right? Which one is your taken? No, he's shown a particular picture of the left, right? No, where was your RCA? This one. So the engagement is done in it's a right coronary artery. You want to engage it, you look at it best from the left. It's like having something and then having a shadow behind it. It's like exactly like this. So you have this light giving you this shadow. So I want to see something en face, I have to see opposite to it. So if I have a RCA, right, which is running on the right of my heart, I have to look at it from the left. So it will be seen into it. So it's an LAO which is taken, right? And then once I see the RCA in its entirety, you can see that the PDA and PLV are overlapping here. Now I want to separate the RCA and see it in all of its segments, which is why I go for an LAO 30-30. This is a 30-30 projection. This one, right? This one is 30-30. So this is not the second view. This is the first view. This is the second view. So you take the RCA, and now what happens is it gives you very nice PL going up, PD going towards the septum. That's enough for me. I don't need a third shot on my RCA. I need only this shot and this shot. This shot is taken if I want to have a doubt on the mid RCA, but more because if the left is occluded, I want to see this coming back here and filling the left, then I take it. So the sequence is this, then this, if needed. Number one, there's nothing like this has to be done. It's never that way, because with each injection, you are shooting contrast into the body. The issue of blood, I told you, is there. More than that, there is a kidney damage that happens with each shot because you're giving more of contrast. So these 5 shots are enough. Let's go over that. Left is RAO caudal, RAO cranial, RAO caudal because you want to see proximal LM, proximal LED, proximal circ. Then RAO cranial because I want to now see LED, mid and distal LED. Then LAO caudal because I now want to see circ. So I have finished my left system with that. Then I take for the right. Right, I want to engage. I take a LAO 45 and I see proximal and mid. Now I want to see distal, which is overlapping. I take this, which is LAO 30-30, LAO 30, cranial 30. Period. 5 shots, your angiogram should be done. I don't think it's that difficult to understand this, right? Because the idea is it's never followed scientifically. Nobody told you ever that this was done for this reason. It's simple. Cranials are seen better. Cranials are better for LED and mid and distal segments. Caudals are better for proximals and LCX. That's it. Nothing else. Okay. Let's go with the intervention part. At least what I'll discuss with them is, put on the lights. At least the material you should know what you should know. Let's not do mumbo jumbo on the PPT. Is it there? Do you have a PPT on this? Otherwise, it's fine. We can just show them. Okay, what are the two types? Supposing I want to do an angiogram. What are the catheters I need? Anybody? Yeah, come on. Let's not. Loudly. JR and JL. Now pick up one JL in this. What is the thing about JL? JL has got two curves. You have a primary curve and you have a secondary curve, right? There are some things you need to know. Is it there? Or even a guide would do. Doesn't matter. Which is the shape I would want to show. Show it to them, not me. Just show it to them. Show it to them. That's fine. Now, what's that in your other hand? What's this? Tiger. Tiger. Okay. So, no, keep it down. Keep the tiger down. So, you see that there are two curves there. You have a primary curve and a secondary curve, right? Now, all of you know that we call it JL 3.5, 6 French. What is that 3.5? What is that 3.5? Third year, guys, yeah, come on. So 3.5 is the distance between your two curves. Guna, give it here. It is the distance from here to here, right? Because what essentially happens is the back end of it sits on the aorta and the front of it hooks into the left main, if you are doing, right? So that distance is measured in mm, but in common parlance of saying it, it is converted into centimeters. That's all. 3.5 means 35 millimeters. So if you have a dilated aorta, what will happen? Your 3.5 will not sit. It will start wobbling because this back end is not touching the back end of the aorta at all. So you need a 4. Okay, I mean, we have those catheters. Somewhere it's there. But then the idea is you need to take a wider catheter or a larger catheter for a wider aorta. So what I expect from a tech or anybody when you are working, Dr. Sola was telling you, you should join a big hospital. The idea is that you'll see a lot of people working in different ways. They all come from different backgrounds. They've been trained, someone in PGI, someone in AIMS, someone in XYZ, whatever. But more or less everybody understands the same, that number one, whenever you take a patient up for an angiogram, look at the fluoro. Right? When we are not in the lab, I'm scrubbing, for example. Take down your fluoro, just do a fluoro shot. In your mind, you will learn when you do it 10 times what is a dilated aorta. You will see it because you will see the aorta getting dilated. All of us know, right? Cardiomegaly, you see the aorta is large. There, if you give me a JL 3.5, it's not going to work. What will happen is there will be just some time lost. You will give me a JL 3.3. I'll go there, sit there, try to hook, and say, Arey, yaar, the aorta is so big, give me a 4. You could do it initially. Just keep your leg on the fluoro. You should do this, right? For a second. Just see how wide the aorta is. Do you have he has this angiogram. Oh, you don't have an angiogram. You have an X-ray anywhere? I could just show you there. Because if the root is dilated, it just means that you need a larger catheter. One. The second, and the same thing works for a guide. You have a diagnostic here. What is the difference between a diagnostic and a guide? A diagnostic is used for name, yeah, come on. Diagnosis, right? And a guide is used for angioplasties. So we have an it's the same technique. The technique doesn't change. Do we have a guide? So, no, this JR. JL show me. JL show me. Because JL would tell you whether, now this is a JL guide, right? This is a JL guide. It's got a 3-layer braiding. What do? Supposing I take a catheter and I cut it, right? And if I do that in a guide, what is the difference between a guide and a cath? It's okay. It's okay. Doesn't matter. If you have it, get it. If not, it's fine. So you have an extra layer of steel braiding there. It's called as a Kevlar. Kevlar is actually a Russian word. So it's a steel braiding inside. Why is this important? Because this is meant for something else. This is meant to be a carrier for wire, for balloon, for stent. This needs to be sturdy. It needs to be, hard. While a diagnostic is much softer. That's fine. It looks the same. But if you feel it, you would understand it. So this is a guide. This is what she's telling is a guide. This is much stiffer than a diagnostic is. And what could happen on a bad day, again 7.5 Shani, you start with a diagnostic and you are learning angiography. Your junior resident hooks it and kicks off the left main, dissects the left main off. You have a diagnostic. Diagnostic will not allow a wire, a balloon, a stent to pass. And if you remove your diagnostic and whoever diagnoses it comes and says, "Arey, take it or let's put a guide," the left main will close off. It can, and it has happened multiple times. So you should be very careful. It's not that you do a diagnostic with a junior and then you should take it as a worst case scenario every time. You assume that this is going to dissect. And our training is like that. You always think of the worst things, right? The second guide that comes commonly you would have used is an XB. You have an XB guide? An XB is different from a JL. It's got only one curve. You have an XB guide? Okay, I can show you in the picture otherwise. So in an XB guide, you have only one curve. And it is a much more sturdier guide than a JL does, because I think the coronary comes a little later. I had put more of congenital because not many people have done congenital. That's fine. So see if it's there. So basically it's a U-shaped guide which gives a lot of support, much more sturdier than a JL does. So an XB guide is an extra backup. You will hear it as an EBU sometimes. It's said as an EBU. It's extra backup. Or if it comes from another company, it's XB. It's the same basically. There are other guides. Any other guides anybody can name? Which one? Contralateral? No, I mean I don't know the guide. What's that? Contralateral? Contralateral support, CLS guide, is it? Okay. There's one which is called as Amplatzer, which we all know, right? And Amplatzer is a much more common guide, which it has the U kind of shape. It's a very good guide when you have anomalous vessels. Supposing it is not coming up the own way, you see there is a U-shaped curve on this. Again, it's a U-shaped curve and it sits very sturdily on the aorta. And typically if you have an anomalous right or an anomalous left, it is an AL, but it can be used for the right, particularly if it's anomalous. So this was shown in Vaidehi. Actually, Vijay Sai sir was the internal then. So they had kept all of this just 2 years back. And they asked, because not many people use it, but you should know that it is used. There are other common catheters which are used. I'll only go to the common ones. Tiger. Now, Tiger catheter is very commonly used for radials in most parts of India or the world, right? So a Tiger catheter is actually, what is the name of a Tiger catheter? Anybody? What is the actual name? Optitalk. So it's called as an Optitalk catheter. So no, we just had one, right? It doesn't matter. So any other catheter for the radial, do you know? There's a catheter called Kimni, which is available in Bangalore. Dr. NH uses that. I forget his name. I think Pradeep Shetty sir. He uses it. People from NH have seen this. So if they keep it like suddenly, it's called as a Kimni catheter. Though of course it looks like a Tiger only. It's not too different. There's something called as a Jackie catheter. JACKY. At least know these names. Okay. These are available in India. They are used, but they all look like a Tiger only. Nothing great. Then, okay. Then after you have diagnosed it, now you want to treat, right? How would you start an angioplasty? You start with a guide. You see a lesion. What do you do first? You cross the lesion. What do you use to cross? Wires. So when you talk about wires, what are the common wires that you know? Run through? Okay. So the thing is, the Teflon and the Terumo are catheters that carry the guide there. They are not coronary catheters. Coronary wires. I'm asking you about coronary wires, which cross the lesion. So the commonest ones are many. They are called BMW. Cyan Blue, Run Through, Whisper, Cross It. So they are all meant for a certain job that they are supposed to do. The common ones that you use in the lab, as you mentioned, I don't know if Cyan is used as a common wire. Cyan is generally a wire for a CTO, but BMW is used as a workhorse wire. So a workhorse wire typically is a wire which you use day in, day out in the lab. For our lab, it is a run-through. There's something called as a run-through NS. It's one of the commonest wires used in Bangalore. BMW is also used. Galio is also used. Galio was used in NH earlier. So this is a wire, but all in all, what it means is it's a workhorse, means it's a soft wire. It's not a hard wire for a CTO. It's meant for a regular lesion where it is supposed to cross the lesion. You pass your balloon or whatever over it, stent over it, and eventually this is meant only as a transport medium for your this thing, material. There's something called as a support wire, where this wire goes in first and you put a second wire there because your material is not going in. Either the artery is tortuous, calcific, whatever. So for a support wire, you can use another wire like this, which will be then called as buddy wire, BUDDY. Okay, so a buddy wire is a run through, is actually a workhorse wire, but another one. So you put one and you put another. So the wire straightens out the artery. Or you could use a wire like what is called as a wiggle wire. Is it there? I don't think we have a wiggle here. So wiggle wire is another wire. It's also there in Bangalore. Some doctors use it. Dr. Nausundi uses it. I've seen him use it because he does all those complex calcium and all those cases. Anybody who does that would have seen. So it's like a wiggle. Wiggle basically means like a wave. So it straightens out the whole artery. It's a very sturdy wire. It's not a wire to work on for your PTCS. But you put the first wire, put the second wire, straighten the whole artery and then do it. So we can use this wire itself, which we do always, or like commonly, or a support wire can be used. Now, two things you will be asked. It's a very descriptive talk. I don't think I'm going to discuss that. But the point is, there's something called as a hydrophilic wire, correct? So a hydrophilic wire will take in water and it has a coating. So it slips through the lesion better. You want it to happen and you don't want it to happen. I'll tell you what it means. Supposing it's a tortuous lesion. You want the wire to go through, but you do not want it to go into a wrong plane because it can slip through anything. It can take a microchannel and then go out of the heart. Out of the artery. So it can perforate. So you should be careful when you use this. These sound very hot in their names, but trust me, when you start using them, there's a wire called choice PT. PT, right? PT stands for platinum tip. My teacher used to teach it as pericardial tamponade. Almost always, if the second operator is not holding the wire well, it will go ahead and it will perforate because it's a very strong tip wire. So there's Miracles and Ultimate Bros and Conquest. These are all wires which are extremely difficult and dangerous to use unless they are required for. I know a cardiologist who's fighting a case because of this in Bangalore, because he has been proven that he used a wire that was not required for it. Doesn't matter who it is. The point is these can kill. This can perforate and can kill. Now, after you put in a wire, let's say you put in a wire, any of your wires, you put in a whisper, you put in a run through, you put in whatever. After that, what do you do next? You want to dilate the artery, correct? So for the dilation, what do you use? Balloons. What balloons? There's a word before that. You want to use a compliant balloon or you want to use a non-compliant balloon. Supposing it's a regular lesion, a compliant basically means when you inflate it, it expands radially and it expands longitudinally. That's what compliant means. The more you inflate, it will start expanding this way and start expanding this way. You do not want to do this after stenting because you've stented already. After stenting, it's better to use a non-compliant balloon. That means if you expand, it only expands radially, not longitudinally. It will not dissect. A semi-compliant goes this way and this way. You can use that for pre-dilatation. Stent balloons inherently are semi-compliant because they want the stent to expand in all directions. That's understandable. But once it's expanded and it sticks to your artery, how do you fix it? You use a non-compliant balloon. So a non-compliant balloon which is there is, you cannot really make that out looking at this. You can't, right? You have to go with the manufacturer's thing. So they all come in sizes, 3 by 13, 3 by 15. Non-compliant balloons are always small balloons. They are not long balloons because they give radial force. You want to go in a certain place, expand, deflate, go down, expand, deflate. It's like that. So you want a thing to expand neatly your stent, use a non-compliant. After stenting, pre can be a semi-compliant. You can use a non-compliant also, but the entire funda is that you can expand it more and like in both directions, but don't go too high from what they call as the nominal or the burst pressure. Nominal is up to what it gives you the minimum length. Okay. Now in this, very, very important for CCT, particularly the third year guys, what kind of balloons are you going to use if the lesion is not the usual run of the mill? Supposing it is calcific, what do you do? We use what balloons? There are certain balloons you use for calcium. So they are called as score balloons. Scoring basically means score is a blade that nurses use in the ward to cut a tablet, right? It's like a wire and it cuts through. It's a wire. You have a balloon on which a wire is wound. So when you expand it, it cuts through a lesion, and heavy calcific lesions cannot be done with this. It can only go through a fibrotic or a mild calcific lesion. So a scoring balloon, SCO, this has come as a short note. I think in your batch, Guna, or your senior batch. One of the batches very recently, scoring and calcium gave us a 5 marker. So, and it will come in the days to come because we are all dealing with calcium now. Expect a question on this. Okay. So this is a scoring balloon, SCORING. There's something called as a cutting balloon. Now a cutting balloon actually has blades. Do we have that Wolverine here by any chance? No. It's given a name of Wolverine. Wolverine is one of the brands. Wolverine is an adjective of wolf. So it's like a wolf's teeth. So basically it has 3 blades in 60 degrees to each other. Like, you have 60, 60, 60. It's like that. So when you open up the balloon, it cuts through the calcium. So these are meant for mild calcium. That is meant for moderate to heavy calcium. So you have to expand it, break the calcium. So scoring and cutting balloons will be asked to you in exams. At least you should know this much, if not more. Okay. Then once you have stented, I told you should use non-compliant balloons. Imagine you did not prepare the bed of the lesion well. Now you have landed up with a stent with a dent on it. Now what do? You have to expand that stent, otherwise you're going to get into stent thrombosis. So you use a non-compliant balloon and you expand it. Didn't work. Now what do? It has not worked. You still have the dent. You stented. You have already stented, but now you have a dent on it. You have to use high pressure balloons. So there you use something called as an OPN balloon, OPN-NC. At least you should know again the names of these. OPN is basically the brand name. It is your normal balloon goes up to what atmospheres? 18 to 20 max, right? 16, 18, 20. OPNs can stand up to 40, 44 also. So you have a special inflator for it, which goes up, 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 and then you want to expand that part of the stent which is not expanded. Of course, at a risk of perforation. Because you might expand too much and it might just draw the whole artery open. That might happen. So at least know the names of these balloons. So you have a wire, you have put in a stent. Now another question comes as stents. Okay, stents is very important. You will be asked about stents. They commonly start off saying, which stent have you seen in your hospital? So at least know about stents. Bare metal stents are not used. Generally now all are using drug-eluting stents, right? So the common drugs that are there in the stent are what? Tell me two drug names. The commonest is sirolimus, okay, sirolimus, SES we call them, or everolimus. So these come as first generation is sirolimus and paclitaxel. Second generation was everolimus and rotolimus. Third generation was the scaffolds, what we call as absorb. That is, there's no stent, there's only a biovascular scaffold which dissolves off. At least know this much. Okay, come back to this. Switch the slides. So what you would not have seen, I'll just go over. What's the time? 5:17. 5:35, 5:40, tell me. Okay. As much as I can, important for them, I'll cover. Number 1, you would not have seen PTMC. Okay, Arun was mentioning about this in his talk. Suitability of the valve, the Wilkins score. At least you should know certain things. Some of these spotters have been kept in exams. We have kept them. Jayadeva has, etc. Now what is happening here? There is a septal puncture being taken. Okay, there is a septal puncture being taken. So we use a septal puncture needle. It's called as a Broken-Brough needle. This is a Broken-Brough needle, right? It is sharp. It goes through a sheath called as the Mullins sheath. And we tried, this is the Mullins sheath. So this is taken from the femoral vein up into the RA. This sits on the IAS RA side. You pass the Broken-Brough through it and the sheath goes into the LA. This is what is being shown here. So this is, I'll go full screen. 1 second. So this is stuck here. In any case, so this basically goes into the LA, and once it is done, you can get a puff and you know you are in the LA. This is called as stenting of the septum. The one that you see on the left is actually called as stenting, where we tent the septum and then eventually puncture it. So this is something which is taken for entry into the LA for whatever reason. Most commonly for a BMV, balloon mitral valvotomy, it can be taken for left-sided EP tracts and everything, for putting a mitra clave, for whatever, LA occludent, all of that. Then this is a 10 marker that is generally asked to you in exams. Okay, so like PTMC, what are the indications? What are the contraindications? Then what are the risks? What is the complication? All of that is usually asked. So please read about that. This is how the balloon opens. You have a distal balloon and then you have a proximal balloon that opens, and then your LA pressure has come down significantly. You will be asked about what is the name of those balloons, right? The common ones that we use is the Acura balloon. Acura balloon is not a BMV balloon, it is a pulmonary balloon actually. But then it is used for the mitral. So if you go down south for your exams, there is a balloon called as Jomiva. This is used only in CMC Vellore. It stands for Joseph Mitral Valvotomy. George Joseph sir actually designed this and they still use it. It's Jomiva. So it's Joseph Mitral Valvotomy balloon. Double balloons we never use now. We used to use during our residency. Nobody uses that now. So this is the balloon. This is the Jomiva balloon. It looks a little different from the Acura. The one on the left is Acura. The one on the right is the Jomiva. The one on the extreme left is the Jomiva. This is the Jomiva. Okay. This is the Acura. This is the Jomiva. But they have used it. Nothing really different. They patented their own and they did that. In pulmonary valvotomy, where would you do that? You would do pulmonary valvotomy when there is pulmonic stenosis. So if there is a PS, then you would do this. Important points to remember in this, I'll not go into the details, is that in a pulmonary balloon valvotomy, you never really go, in a pulmonary, you go more than the annulus. Supposing you have measured annulus, where do you measure the pulmonary annulus best? In an echo, in a PSAX view, right? So once you see it is, say for example, 10 mm, you can go with this balloon 120 to 140 times, 140% more than it. That means you can go up to 12 to 14 mm and actually expand. This is something you cannot do in an aortic balloon valvotomy. When you do an AVBD, aortic valve valvotomy, you never expand beyond the aortic annulus, never. Pulmonary, you can do that because your pulmonary valve is elastic, PA is elastic, it can accept flow. Aorta won't do that, it will cause AR. So the indication of pulmonic stenosis, pulmonic valvotomy is if you have pulmonic stenosis. Nothing there. It's like a no-brainer. So PS is there, you do a PVBD. That's all. AS is there, you do an AVBD. The key points is that mild PS has no benefit. So only moderate to severe is done. And generally in the younger ages, it is done for congenital PS. Rarely it is done in TOF. If the child is very sick, your surgeon is not taking it, then you do it as a bailout. Otherwise, these are clean, neat patients with PS done, and they usually 70 to 80% of times do not come back to you. They'll be doing good rest of their life. Unlike AS, which comes back to you. So this is how, this is where a tech comes in. How good you are as a tech is where it's seen that if you see PS, you should be able to see whether it's a bicuspid valve, whether the valve is the problem or subvalve is the problem. Supposing it's not here, it's here, that's the block is. You have a bundle there. PVBD is not going to work. So you see a doming valve like this with this signal, only then it is good for pulmonary valvotomy. Choosing the balloon size, I told you, you can go 120 to 140% of the annulus. You can oversize it a bit. So this is how you have a tight valvotomy, a tight pulmonary valve, and when the balloon opens, you see that there is a waist there in the center, which opens up. Okay, and it opened up well. So we cross the wire, we put a balloon there, and you see right there, you can see that there is a white constriction which opens up. So that's the valve. That's a stenotic valve. As I told you, this is not a balloon for, your original balloon that you use for mitral valvotomy is actually a pulmonary balloon. So Acura can be used even there. Sometimes when if you have an IVC interruption and you cannot reach the heart, you have to go from the neck. It's called as a jugular PVBD. Then let's go to, this is something that you should know, at least going to, like for some institutes in the south, which is a Melody valve. Supposing a patient has had a TOF procedure, okay, and the TOF procedure, basically TOF surgery, means you cut open the pulmonary valve. So it becomes regurgitant. This is something again that Vijay Sai sir had actually touched upon. That once you do a surgery for TOF, PR happens. Now, is the child going to tolerate PR all life? No. 10, 15, 20 years down the line, the arteries start to get dilated. Do you want a second surgery? You can put this valve. This is called as a Melody valve, or a venous P valve is also available now. It's a valved conduit where you have a valve inside, you go in like a tower from the leg, no open surgery again, go there, stick it open, and it will prevent PR from happening. Costly though it is, it's available very much in India now. Particularly in South India, they'll ask you this. A lot of Hyderabad does this, a lot of hospitals there, a lot of hospitals in like Madras do it. It's available under like schemes now. So you should at least know the name. One is venous P, the other is Melody. So you have, if you do this, the freedom from reintervention is very, very high, actually. So AVBD, you do it just as you do a pulmonary valvotomy for a PS, you do this for a AS. So the ideal patient is, it can be done in adults, rarely, but generally we do it as a, this is not important, we do it in children, where we cross the valve retrograde. That means we have taken a puncture, go across it. AVBD was asked for indications, contraindications, and complications some years back. So you should know that we cross the valve from the femoral artery, go down with the wire, and just dilate it. It's not such a, see, it's like this. So you basically have gone retrograde from the leg back here into the LV, and then over this you have dilated. So it's not something which is, another point is about pacing. Whenever you do these procedures, one thing that we always do is put in a catheter in the vein and pace fast. Why? What happens with that? The cardiac output drops, your balloon doesn't bob. It remains where it should. It doesn't go up and down, okay? So to keep it steady, you can do this. This is a balloon inflation of the aortic valve, and it drops pressures quite like this is, these are the steps. Right, first you have shot, you have seen that there is a doming valve here. Then after that, you have crossed the wire into the LV, and the balloon has opened it up here. This is in the LVOT and the aortic valve. And in the end, you would shoot to see if you have done all good. That is, you have not caused a AR. I don't think it's playing the last one, but then it's about whether AR is there or not there. Rarely, the valve is very tight. We try from the leg to go from the aorta to the LV. It doesn't go. We try once, try twice, doesn't go. What do? You can do something called as an antegrade AVBD. That means you puncture the RA to LA, just as you would do for a BMB. Put a wire in the LA, LV, take it out of the aorta. It's easier to go this way. Take the wire out, snare it, pull it down out of your vein, go then ulta, and then try to do it. So this is something which is called as an antegrade AVBD. You have crossed it from the femoral artery. You have gone down into the LV, clean and clear. This is your normal AVBD. You are not able to do this. How do you reach the LV? You have to enter the LV, right? So here you take a transeptal puncture. You go RA, LA, LV, put your wire there. With the natural flow of blood, it will come out from the LV into aorta, down into the descending aorta. Snare it there, pull it out of the FA, go retrograde, and then work on the wire. This is called as an antegrade AVBD. Trust me, this looks difficult, but this was asked as a spotter. This was just kept as a spotter once, and our girls kept, like Cayman said, we have never seen this thing. It's nothing different. The point is your snare is the clue. Otherwise, you don't need this. See, once you see this, you know that it's like a regular AVBD anyways. But you see how we have done this. I'll go over it again as it happens. So we were not able to cross it. Initially, this was a shot taken, right? This is a very tight valve. We tried to cross it from the leg. It didn't go. I'll show it as it happens. Actually, multiple problems were taken after. So now this is how we are trying to cross. It doesn't go. It goes, hits, and then comes back. So now we have gone. See, how has this gone? RA to LA to LV. You know, it's going this way. And the wire then comes out of the aorta. From the LV, it will come to aorta only, no? Because you have the flow of blood. It's easier this way. And then it is snared, pulled back, and then you do a regular valve dilatation as it would be. It's called as an antegrade AVBD. One thing that you would be asked very commonly is about AHD, VHD, PDA closures, something which I thought sir would discuss, but we can do it here now. So AHD device has to be done as a closure when the shunt is significant, when it is more than 2:1, 1.5:1 or 2:1. There we can show them a device if we have. So it's done as a procedure without even taking an arterial access. So you just go from RA to LA, right? You cross it across. Intracardiac echo is not required. So your basic steps are these. You just cross from your venous axis. You have the RA, LA here. So you cross from the RA to the LA from the leg, right? You park your wire and then you just neatly put in a device and come out. It's very easy. This is an AHD device. You can pass it around if you want to. So this is an AHD device, right? Sizing of the device and all might be asked to you, but it's more of for interventional cardiology rather than for you. But you should know that device closure is done, and the indication is generally when the shunt is significant. The problems that can happen is, always remember, it's very important as a tech to support us in this case. Aorta should not get impinged. The device should not oversize. LA should not be, the device should not be deformed. LA should not be stretched open. It can perforate. So though these are safe procedures, it can land into problems if your sizing is not good. That's how it is. It goes from the leg, femoral vein, RA, LA, right? You open up your device, first disc, LA disc open up there, and in withdrawal, you open up the RA disc. That's all that the procedure is. It can be done pretty fast if your sizing is correct. 3D images and all are not required, but people tend to use them when you have multiple devices, etc. This is the AHD device. The common names are, when we use is Amplatzer, which you will hear more. We use something called as a cocoon device. People from Jaydeva will talk about Figula and the Oculonix device, also called as a Revarp device. They use a lot of it in Jaydeva. At least know these names, okay? REVARP, Revarp. Gore Helix is something that we started in our hospital long back. This was the first in the world done in this hospital in 2009. It's not available anymore. LifeTech is also used. Cocoon is something that we use a lot. And when you talk about, in the exam at least, use the word ASD device rather than saying Cocoon or XYZ, whatever. Clamshell and all is not used these days. Occlutech is something that both NH and Jaydeva use. And if they ask you what is a device that if you use devices, at least know these few names. Remember that it's not a course that requires you to know it in too much depth, but you should know at least as a tech, the echo support for it. For example, now I'm talking about VHD devices. This is actual closure. So we have done like double device and all that, two AHDs. VHD closure, it's the same indication. There's nothing different in that. The shunt is more than 2:1 is when you would do it. So you first have to stand up for the fact that you should do something about it. If the shunt is too small, why would you do it? So the shunt has to be more than 1.5 or 2:1, then you would do it. If it's a VHD, it's the LLALV that's dilated. If that you can see, again, that is obviously a fact that, naked eye is saying that your shunt is more than 2:1. So where is the location? I think Vijay Sai sir touched upon it. Subpulmonics never close. We don't do that with device usually, right? Subaortics are the ones commonly done. Muscular ones are the most common done, but usually they close off on their own. But if they are there, it's easy to do it because you have got good tissue on either side. So subaortic can be done, muscular can be done. Where do you get this kind of a VHD, apical VHD? Sir has shown you one image in a VSR. So, if somebody has a MI and this septum ruptures, it's usually an apical VSR here. So that can happen, that can be done, but that's a different ball game. It's not a congenital VHD, it's a VSR, septal rupture. So this is something again that Vijay Sai sir showed. So this is like what he said is 10 o'clock to 2 o'clock. So there is subaortic here or what we call as perimembranous. Here you have the outlet, subpulmonic, right? So this is not usually done. This is done. And if there's muscular, I think in the next slide here. So if it is muscular here, these can be done neatly with the device. This is more difficult. This is the apical VSR I'm talking about. Amplatzer again is the commonest name that you'd use for a VHD device closure. We can share this actually with you because going into depth of it is a little difficult because all of this, though the criteria as such is not different, the same shunt is taken. Suitability is always an issue. It should not be that you impinge on the surrounding structures or you leave a chance of embolization. So we have crossed into the LV. First thing is to shoot and look for a VHD. Then we create what is called as an AV loop. That means you take your wire in the PA, right? Keep it there with the snare. You cross the VSD, come to the PA, again snare that wire and come out. So this is called as an AV loop here. So I'm crossing the VSD with a wire. I already have a snare in the PA. This snare is sitting right here. This wire is crossing. Once the wire goes there, I catch it, I pull it out. So this is called as an AV loop. An AV loop is actually created with a snare. So once it's done, over this track, you would put the device. So this again is one snap that was shown. Yeah, sure. PDA, sir, like sir had mentioned this very briefly. He spoke of a classification called as the Krichenko. Okay, the Krichenko classification. The Krichenko A, B, C were given by cardiologists, by cardiac surgeons. Sorry, Krichenko is not a cardiology classification; it's a cardiac surgery classification because they can ligate with their this thing or not, suture or not. D and E we have added because we can then decide whether to do device or not. So D, as sir said, D and E: conical, window, tubular, complex, elongated. Complex and elongated is not done by device; it's done by surgery. So this is, if you have a good place to put your device, this is called as the ampulla. This is that cone that you're talking about. It's called as the ampulla. So you should have space here without impinging upon the aorta. That's all that matters really. This is even done in very small children. If you've heard of something called Piccolo device, it's used in very, very small infants, 500 grams, 750, preemies, premature kids. So the first job is to see the PDA and then to cross it and then put in a device. This is a much relatively straightforward thing, not done with an AV loop. VHD is usually done with an AV loop, but it can be done without an AV loop also. PDA doesn't require an AV loop usually. You just cross from the vein, PA, down into the aorta and then deploy the device and come out. These are asked in exams. That's why I'm just trying to cover it. One last thing which is done, which is expected, which has come, is coarctation. Okay, coarctation is basically when there is a narrowing of the aorta. Let me just show you that, and then we'll stop. So this is the PDA. 1 minute. So this is how a coarctation looks. I've actually crossed it. This starts from the point of crossing. Here you would see the coarctation. When the shoot comes, this is the coarctation here. So you have the narrowed segment there. It's just like opening up a tight stenosis. You have crossed it from the leg. Once you define it, you keep a wire there, right? You keep a wire there, and then you take your sheath beyond the coarctation from the leg, come back and dilate with a balloon. In children, you do with the balloon and then you stop. You don't put in a stent. In an adult, you would end up putting a stent. Sometimes you have to end up putting a redilated stent. So I think most of it is what they're going to ask you in the exams. I know about the sequence of all the questions that are given to us as key. Always go read about PTMC. Don't go for the exam without reading PTMC. Because there are about 10 or 15 questions which they have given examiners as a list that you have to pick up 10 markers from that. Right? PTMC is one. AVBD is one. PVBD is one, which generally we don't prefer. We've put it as a 5 marker because many people don't see it. See, when any of us puts a paper, we would think about what you guys see most commonly. So angiogram will always be asked to you. Steps of PTCA will always be asked. Treadmill will always be asked. If you are read about the protocols, good, right? If you know about the Norton modified Bruce, write about that. You'll always be asked. Cardiac cath will always be asked. That's something we could not cover. It's not possible to cover entire cardiology in 8 or 10 hours. But cardiac cath is almost always asked, right? Step up, etc. What is the level of step up, etc. That is asked. What is generally not asked is complex congenital heart disease, arrhythmia. That's why we skipped that VT talk because it's not generally asked to you guys. CHB is there as part of a 10 marker. So please go read about that. PTSMA is not asked. That's alcohol septal ablation. If you know about these indications, great. Devices are asked. ASD device is there in that. VHD device is not. PDA device is not. So these are things which examiners are given a list of and said, you have to put your questions from here. Right? So at least go read with these. All the best. Chalo. Thank you.
Thank you, sir, for this practical session. I would invite Vanilla to deliver the vote of thanks.
Pacemakers is always asked because that's what Anand had finished. So they might show you this as your spotter, right? At least go read about single chamber, dual chamber pacemakers. At least go read about that. Sorry. Thank you.
Saram to all. I offer my humble pranams at the divine lotus feet of our Bhagavan Sri Satya Sai Baba, distinguished faculty, eminent speakers, honor guests, and dear colleagues. Good evening, everyone. It's my proud privilege to propose the vote of thanks for this enriching conference. On behalf of the organizing team, we extend our sincere gratitude to everyone who contributed to the success of this gathering. We are deeply grateful to our esteemed speakers whose insightful presentations, clinical expertise, and evidence based discussions have truly enhanced our knowledge and inspired us to further improve patient care. My sincere thanks to our in house faculty for their constant guidance and support throughout the event. I would like to specially acknowledge the Crystal 2026 organizing team for their dedicated efforts, planning, and coordination in making this conference a success. I would also like to acknowledge the HMIS and AV team for their continuous technical support and ensuring the smooth conduct of all sessions. A special thanks to the canteen team for their timely arrangements and support. Finally, I thank each one of you for your presence and contribution. I truly hope this conference has been academically enriching and will translate into better clinical practice and improve patient outcomes. With this, I conclude the vote of thanks. Thank you and wish you all a safe journey ahead.
Now we proceed on to Mangala Aarti.
जय जगदीश
हरे स्वामी सत्य साई हरे
भक्त जना संरक्षक भक्त जना संरक्षक पति महेश्वरा ओम जय जगदीश हरे शशिवदना श्रीकरा सर्वा प्राणपते स्वामी सर्वा प्राणपते
आश्रित कल्पलतिका आश्रित कल्पलतिका आपद बांधवा ओम जय जगदीश हरे मात पिता गुरुदैवमु मरियंतयु नीवे स्वामी मरियंतयु नीवे नाथ ब्रह्म जगन्नाथा नाथ ब्रह्म जगन्नाथा नागेन्द्राशयना ओम जय जगदीश हरे ओंकार रूप ओजस्वी साई महादेव सत्य साई महादेवा मंगल हारति अंधुको मंगल हारति अंधुको मंगल गिरिधारी ओम जय जगदीश हरे नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा नारायण नारायण ओम सत्य नारायण 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 ओम नारायण नारायण ओम सत्य नारायण नारायण ओम सत्य नारायण नारायण ओम जय सद्गुरुदेवा ओम शांति 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 समस्त लोका सुखिनो भवन्तु समस्तलोका सुखिनो भवन्तु समस्तलोका सुखिनो भवन्तु ॐ शान्ति शान्ति शान्तिः जय बोलो भगवान श्री सत्य साई बाबा जी की
शुभ जन्मोत्सवम्